Vážený pane vicepremiére, vážený pane ministře.
Dear Vice Prime Minister, dear host, ladies and gentlemen, allow me to open the fourth year of the conference called Economics of Prevention, organized by the Health Daily. I would like to welcome all participants and express my hope that also this edition will be full of inspirational ideas and contributions. Once again, we meet in a very representative composition of participants with presence of leading medical, political experts, representatives of top health insurance companies, economists, analysts, and other important personalities of our expert and public life. We are also very happy that our partnership with the National Sports Agency has continued, and therefore also this year we will welcome here representatives of Olympic Games winners and Football League winners. Their contributions will for sure increase visibility of the importance of health risks prevention among the largest possible public and audience. During this conference, we will try to analyze the most important politics of health risk prevention and to formulate certain recommendations for both medical sector and other experts. We want to treat the topic of how to continue in health risks prevention. All those recommendations will be recorded and get published in the Healthy Daily, as well as all ideas and inspirations that will be shared in here today. In the end, allow me to thank the conference partners for their support. This is the General Health Insurance Company. I welcome here its CEO, and we congratulate him for the landslide victory for the next mandate of 4 years. He will again lead our very important institution for health public in the Czech Republic, Mr. Kabátek. Also, counterpart the Slovak Republic joined us for this conference this year. Other partners I would like to thank as well as Health Insurance of the Ministry of the Interior, the National Sports Agency, the company Akesor, Ewing and Discaria. At the same time, I would like to thank our media partners, the main partner, which is the Czech television, and other important media partners such as Czech Press Agency, Tlačová agentura of the Slovak Republic, and one of important news server, start.sk. Now I would like to pass the floor to Tomáš Cikr, the editor-in-chief of the Health Daily, that will moderate the first panel. Thank you for your attention. Thank you, Mr. Ivo Hartmann, who is editor and owner of a media network that publishes specialized health portals, Spravodajský deník and Ekonomický deník. Allow me to open the first panel, during which we will speak about support to public health. State Secretary, take seat. Hello. Let me congratulate the State Secretary for having overcome the risks and pitfalls of D1 highway and to come in time. Our Minister of Health, Mr. Válek, welcome. Slovak Minister of Health had to excuse for her absence due to a difficult situation. She had to stay in Bratislava, sending instead Dr. Ladislav Slobodník, the State Secretary for the questions of health. And as Mr. Hartmann, the publisher, already said, our conference is interconnected with the idea of sports, with the idea of exercises and movements. I'm very happy that the best scorer of the Czech national football team, and by the way also winner of the German and Belgian football leagues, came to join us today, Mr. Jan Koller. Different questions were prepared for today, and since our minister has prepared in this respect also very diligently, he prepared a short contribution, príhovor, as called in Slovak language. Take a micro with you, please. Better. Yes, why not a príhovor? As a matter of fact, the paper was prepared by Mr. Dušek, and therefore it cannot be as short as you may expect or wish for. Anyhow, prevention is a basic topic, and economics of prevention, it's simple as that. Every crown saved in terms of prevention measures applied effectively gets multiplied in return. It's a long time ago I studied medicine in the last millennium, and Zbrojovka team played the best league. Today the situation is just reversed. Sorry for that. So everything changed. That's the idea. And I would like to say that prevention has still always been a basic supporting idea for all my considerations and dealings, and it should be really, there should be a body that would coordinate a policy of public health across different entities of patients' organizations and across expert organizations. Prevention can be divided into two aspects. Your own personal prevention, what you can do for your own health. This is something which is usually not emphasized enough. Imagine your personal car. If you take a good care of your car, it drives properly. It's not only filling your engine liquids, preventing car crashes and so on, having it in your garage. This is something you usually do, but you do not do so much for your own body. You do not put in material and liquids that are beneficial for the body. You do not protect it enough. You do not, treat it gently when necessary. And when there are some warning signals, such as something is squeaking in your body and something is not going okay, you do not usually attend your doctor immediately. And you consider quite not necessary to attend preventive examinations when you are notified of them twice a year. So what you can do for yourself is something very important. Prevention measures are completely paid for. Preventive examinations are free of charge. You do not have to wait long queues because accessibility is really high, not only geographically but also in a timely manner, and therefore we are without preventive system already at the level of districts, and mantra that there are worse districts and better districts in terms of prevention available, this is not applicable anymore. This is not true. I am happy that a certain debt was paid back. When I was chairman of Radiology Society, Mr. Kabatek was already the CEO of the General Health Insurance Company. There was a commitment we would buy a certain number of medical devices, but they were rather bought for certain big places such as Brno, Prague, and not for faraway districts. But this is not true anymore. This has been repaid for. Preventive measures and specific results out of it, it was mentioned, it was found out that colorectal examinations, that there are long queues of waiting. This has been also corrected. This program is being put in place. The second problem identified was a lower accessibility of breast cancer prevention. Karlovy Vary region or Bruntal, it was definitely improved there. Safe and high-quality prevention program. This also has been put in place. There is a supervising body. There is a national screening center that's coordinating all the screening programs, surveying their quality. It is necessary, especially if it is in relation with population screenings. The quality cannot go down, cannot decline. A typical example, breast cancer preventive screening quality went down and different problems rose. Well, we can use AI, of course. We can use telemedicine and teleradiology, but only in part, because these ways, Professor Strickland in England, in Germany, a specific group, turned out to be more expensive and still having a lower quality. So it's necessary that we also analyze cost and value analysis, and we made analysis of quality of screening centers for prostate cancer, for instance, because maximum idea of my mother company was, to use 3 Tesla magnets. This is not necessary because the device is too expensive. It is rather for brain examination, so a lower capacity magnet is quite well usable. On the other hand, we made a very large expansion of prostate preventive screening. No problem with that. You do not have to fear that if you are men. It's really something that is very well done today, and we do it with IMG, which is quite a perfect way. Prevention must be governed in a modern way. In other words, it must be digitized. The information must be provided online, both to patient and to the provider of healthcare and to the health insurance company and to the state. When I started working in my current position, there was a terrible situation. There was the end of 2021, and based on the findings of management of the health system and digitization, I had to change completely both the management composition and the approach to digitization, because today we have coordinators, we have devices for more than 600 million, we have 30 experts that have been coordinating that with experts from individual hospitals. All comments were incorporated. Next year we will launch all 20 programs of digitization, and if Parliament doesn't put any obstacles to it and will enact digitization of healthcare act, it will work. What will be the result? There will be a perfect back office for all those digitization processes. We've been working already on it, and we will launch it next year. Also, EZ card has been gradually implemented. This will be about vaccination. Patients will get, or population, will get their vaccination passports, including notifications to present themselves for vaccination. We implement data across the segments. The health system is well interconnected with the social system. USIS, this is Institute of Social and Health Data, which is a perfect match, perfect link, and we have probably the best interconnection between the two systems. Prostate cancer screening, pancreatic cancer screening are in place. We are now evaluating whether there are some risk groups, whether it concerns the general population.
We are talking about the aneurysma of stomach aorta and the like. So we've piloted over 18 preventive programs. Be Fit 24, focusing on the obesity among children, is considered to be vital, and I'm sure there'll be other people talking about that, because all sports clubs love kids that are slim and fit, but nobody ever fighted for me, and yet I'd like to work out. So it's a type of program for me. It's not important to win or to participate, but to run till the end and survive. That's the way I perceive it, and it's regardless of the type of physical activity that you do. Of course, I'll never be a great soccer player because I'd be in the way of all the other players, but it still doesn't mean that kids with obesity still have a right to do some sports. Diffusion and disability of lungs and other programs are in really advanced stages. Macular edema, oncological diseases and screening, and also detection of heart diseases. And here I'd like to thank the professor of the Cardiological Society who is here among us. And there is also another pillar which modifies preventative screening. Let me emphasize that the Czech health system and the European health system, the Bismarck system of solidarity health system, which shouldn't be Americanized, is facing two hard decades. In the forthcoming days, the number of elderly people will more than double. The population is aging, and we want these people to stay healthy so that it can be covered by the health society. We don't have any other resources but the funding from the state, which means that it's paid by the citizens of the Czech Republic. We'll have to face various types of challenges, and unless we want to raise taxes and medical insurance, which is not the same as social insurance, and it's a big handicap, in fact, we need to work with this aging population, reform the health system, move on to long-term medicine so that the patients on acute beds would not stay in hospitals. We need to increase the number of medical students at medical faculties. Next year, there'll be 350 or 400 graduates more than last year, and there will be 480 million subsidies for the medical sector next year. So, based on the data which is available, we are convinced that the curve showing the numbers of medical professionals and doctors will gradually grow, and this also applies to nurses. In terms of the main challenges, it's the coverage, and that's why we need to raise this issue in Brussels and with the European Commission. It is necessary to take this question seriously. Of course, the health policy is a question of the different member states, but you can travel across the EU, and if there is missing medicine or medical care in one country, it's a problem. That's why the debate about these issues continues in the right direction. Hand in hand with this, we need to support medical literacy and prevention of serious diseases. Nobody can do more for your health than you yourself. It's the patient who can do most. It's not the health insurance company, the state, or anyone else. And if we don't see this, no matter how good the system is and how much money we have, we won't be able to live well when we get old. Thank you very much, and I look forward to your questions. Thank you very much, Minister. After the Q&A session, he is going to... after the Q&A session, there will be Professor Duszek who will talk about the figures. Now, a nice surprise. The minister from the Slovak Republic couldn't come, but she's actually sent us a message. So I'd like to ask the technician to play the video of Minister Dolinkova. Ladies and gentlemen, Prime Minister, medical professionals, welcome to this conference on the subject of prevention. I'm very sorry that I cannot attend this conference in person. I was really looking forward to it, but let me share a few ideas which are important to me as a Minister of Health of the Slovak Republic, and that's the prevention in healthcare. The financial demands in Slovakia as well as in the Czech Republic continue to grow. We know very well today that investments in prevention saves lives and also decreases the cost of treatment. Vaccination, screening or early detection are the basis for a healthy society. The importance of screening is really important because it allows to detect a disease before it starts to reveal itself. We try to attract as many people as possible. One of the challenges we are facing is increasing medical literacy. Many patients don't want to leave their risky conduct despite the fact that they put at risk their own health. We need to provide help even to these patients. And this covers various ideas, whether it's medical or mental health or obesity. There are activities such as smoking, and here prevention is primordial. I really appreciate the connection between the expert view at the conference and the perspective of top athletes. Sports is one of the best ways to achieve a healthy and long life, especially if you focus on children. I believe that this conference will contribute to searching for innovative and sustainable solutions in the area of prevention, and that together we'll be able to create a strong and resilient system for the benefit of each citizen. Today I'll be represented by Ladislav Svobodnik, the State Secretary for Public Health in Slovakia. I wish you a very nice conference and many greetings from Slovakia. Thank you very much, Minister. It is obvious that the accents were the same as what our minister said. The systems are facing similar problems. Now I'd like to give the floor to the State Secretary. You've heard the words of our minister. How about the Slovak population in the area of health risk prevention? Does the state pay enough attention to this prevention? And how about medical doctors and citizens? Thank you very much. Regarding preventative programs in Slovakia, there is a wide selection. It's actually similar to what you have here. But a widespread problem in Europe is keeping the medical care available and increase this availability. This means that we want to attract as many people as possible. The preventative programs can be divided into health or medical part, which is supported by the state, but there is also the area of education. We should actually start at schools, but also within other cultural programs. This means the involvement of athletes and people involved in sports. In terms of the main issues, we too have a wide network, which is well set in my opinion, but we cannot attract as many patients as we'd like to, and we don't have enough pharmacies. Also, medical professionals are really overloaded. So I think the best would be if patients see their GPs, because that's where they put their trust. For the moment, there is a lack of medical doctors, and I think in general we should react more to the cultural needs and educate people starting at primary schools, secondary schools. We should also appeal to parents and elderly patients. So it should be quite comprehensive. In terms of prevention, I think that our basic role as the Ministry of Health is that in terms of infectional diseases, we should continue on the way we started. And I think that both the countries, as well as the whole of the EU, is built on good foundations. And I'd appreciate if most of the vaccines could be covered by medical insurance, which would actually support people's participation, and it would be also educative. In addition to this, we need to deal with information which is freely available on the internet, because people can find information which really is not suitable. Now, a question. How about the participation of people in screening programs? What are the limits to some people not coming for screening programs? What is the potential of screening? Could you start, Minister? Which programs you consider really good in terms of participation, and where should we increase participation? Well, let me narrow this down to oncological screenings. Here, the patients are usually much more aware of their situation, for example, because of their medical history or family history. So they do realize the risks. In terms of population screenings, definitely mammography. This is historical screening. Women realize the benefits and results. The limitation consists in availability and the places where they can go for the screening. Denmark is considered to be an example in digitalization, and the benchmark is that if 60% of people get for the screening, it's a maximum. So I'm afraid that we can hardly expect a higher turnout for medical screening than what we have as a turnout for elections. So many people simply come too late. Okay, in terms of this percentage, are we okay? Yes, I think we should try to achieve 65% turnout at regular screening. In terms of colonoscopy, this is a very safe and fast method, frequently under local anesthesia, so there is no negative experience on the part of the patient. But of course, the preparation for the screening is kind of hard. Also, prostate cancer screening is important. Again, we should increase availability and the network of screening centers, because sometimes you really need to convince people who don't feel any pain or anything. You need to convince them that to go for screening, and they don't feel they really need it, and it's unpleasant, so they won't come. State Secretary, how about you? What's the situation in terms of screenings in Slovakia? Well, I think it's exactly the same. Oncological diseases are our priority. People are very well aware of the risks, especially those with the family history, come by themselves. And we'd like to replicate this throughout the whole system. This concerns especially the cervical cancer screening, prostate cancer screening, and colonoscopy. We also want to focus on the screenings for heart diseases. So, yeah, our experience is pretty much the same. Let me turn your attention to the fact that when we do active screening, we need to cooperate with the people, but there is the problem of missing education.
And my private idea is, when films are shot, that films should be done in such a way that they educate. At the same time, there are different series, such as, for instance, joking moments, how many cans of beer people drink. But there should be some real life shots in those series or films, because people do like watching series, films, and I think definitely they should contain medicational aspect. And screenings, this is something that costs the state some money, and it needs that people get educated, convinced, but this could be a playful way. In Great Britain, they did measure some time ago what is the film of television series on cervical cancer screening, and as a matter of fact, when the actress supposedly died of this anger, the participation in the screening program increased enormously. Yes, exactly. If there is, men and woman, they went together, a couple, for colorectal cancer screening, and we increased, because that was a show, that was a part of the television series, and this was such an advertisement. I even wanted to thank the authors of the news, of the television news where it was featured. It does have impact on people's interest and motivation and participation. Sometimes it may face the problem of capacities. I used both the names. I know one person in person. It was a perfect initiative. But if you look at how many series from health environment are being displayed, there are different surgeons, there are different professions, medical professions featured, but there is no series on screening, which is a pity. So public television should be addressed, and this should be mentioned. Or if there is a chronic disease, whatever, especially if it is oncology disease, if a person comes to a specialist, she becomes a part of screening, but it's not identical as preventive examinations. So it's a sad reality that oncological patients, where through screening the first tumor is being diagnosed, the second tumor is usually diagnosed later than in general public. This is something that the hard data show us. And with Professor Duszek and Marcus from the other entity, we discussed this, how to accelerate this identification of the second tumor, how to adapt preventive examinations so that they get more individualized by sexes and by age, and how to interconnect it with Crohn's disease or whatever other disease that are in the care of a special doctor, a specialist, but not in general. I would like to add that everyone has to manage her health individually. It's not enough the way that a doctor will identify a problem. We have to be our own health managers, and we should collect information. Whatever information we used to read on the internet, we should be interested in reading information about health. Once I find an information, I go further, collecting more information. Yes, indeed. Should any initiatives oriented on prevention be interconnected with some financial schemes in terms of health insurance companies? Should those support more preventive programs? There are funds of prevention. We should like to increase the volume of money available in these funds. This is just waiting for the presidents of the country signature. And we would like to motivate people who attend preventive examinations and screening programs. If you go repeatedly for such programs, you may accumulate some benefits, some bonus points, and you get the information. You provide the information to the health insurance company that then knows who is taking part in preventive programs and who doesn't. So we would like to exactly support that, and those who actively take part in preventive and screening programs and get vaccinated should be somehow enjoying some benefits as compared to others, because these people can show the positive results of these programs and vaccination. And general practitioners are enormously important in this respect. Preventive examinations are so well set up, and still many entrepreneurs pay their employees something they call preventive examinations. In the history it used to be called managerial examinations, but the structure of this examination is not the same as general practitioner examinations. We would like to unify these processes. There is a debate between Ministry of Health and Ministry of Finance, so that we would like to consolidate the programs. If entrepreneurs, for instance, want to participate with their own money in those preventive and screening methods, that the ways are unified, and they again can get some benefits from this participation. Do health insurance companies have any mechanisms necessary for that? Yes, they do. Patients receive different benefits for their participation. More or less it's being coordinated by the Ministry of Health, but benefits for both patients and doctors go through health insurance companies. There are benefit programs. Thank you very much for this information. Throughout the day we will speak about different tools and schemes of prevention, about early detection, about education. We will speak about vaccination, about obesity treatment, but we will also speak about sports. And this is the point I would like to dwell on now. I'm very happy that Mr. Jan Koller is with us here. Mr. Koller, tell me please, how do you maintain your body condition once you have finished your top-level sports activity? Good morning, ladies and gentlemen. In my case, transfer wasn't so drastic due to the fact that when being a child already, I somehow got a positive attitude towards sports. I was growing up in the countryside, and we moved a lot. We spent all our free moments in the open air. We moved and played different games. And then I became a professional sportsman, but I also had a complementary sports activity. And when I stopped being a professional sportsman, I just transferred towards voluntary activities such as ice hockey, tennis, beach volleyball, tennis. So there are different activities, and that makes it easier for me. However, there are unfortunately former professional sports people who do not cope with this transfer in their lives. Yes, and it usually shows. There was a beautiful film shot on you, your way of spending your time in Smetanova Lhota, being fully incorporated in the local community life, sharing different activities with local people. Do you think that could be the way how to improve the nation's health? I mean, sharing activities together. Sure, people in the countryside tend to live in a calmer way as compared to people living in big cities. Local people where I live, they take care of their houses, of their gardens. They move somehow naturally doing these different jobs. And every Saturday, Sunday, we meet for playing leg football. Everyone takes part, even those who normally do not play football, but these leg ball, this is something everyone likes to play, and this is what strengthens the community spirit. We like each other. Of course, there are problems, but since people live in a more peaceful, calmer way, and also healthier kind of way, this is which helps to overcome. So seems that Smetanova Lhota, your location, is a place where I could play myself too. Yes, you will be invited for sure. Mr. Koller said something that inspired me to this question. Sometimes from Prague, we cannot see all the consequences in the country. Very often, the way of living is associated with our health, and often it is also a task that covers several ministries. Perhaps it's an interministerial job to take care of that, supporting different activities, healthy activities in regions, throughout the regions. Yes, indeed, in this National Council for Public Health, which is a top entity that starts to be active now, there are different ministries, not only Ministry of Education. On the other hand, I would say, and Mr. Koller will probably confirm it because he's a better expert than I am, hard to imagine better places than kindergarten and elementary schools as to where to start educating people for sports. So it's especially on the educational level that sports must not be forgotten. But if a pupil is afraid that she would get a bad note because not physically equipped, ideally, this is, of course, something that has then far-reaching consequences later on in lives of these people. So to improve relationship between sports and individual people, of course there is more and more people who watch Olympic Games and football championships, especially if it takes place in our country, in Prague. But it doesn't have such a far-reaching impact on public health. So we can help building public courtyards, but money that is, for instance, in the funds of municipalities. There's more money than the national budget has. So at the level of municipalities, it should be further stressed out. And I would also like to add that when I studied partnership between public health and different sports events, for instance, Olympic Games in London. Every country, of course, wants to succeed, and they invested a lot of money then, and the Minister of Health supported it by saying that every Olympic Games winner attracts thousands, millions of children to do sports. And the only statistical data they had to support this was that something as, 1 million or 10 million pounds invested in the Olympic Games reduced obesity of children by 3%. That was the only statistically significant data. So ways are here. They seemed easy. It's good that we have top-level sports persons attracting other people, but these ways do not seem the most effective. There must be support brought by Ministry of Education, supporting activities as early as in the kindergartens and elementary schools. Okay, Mr. Kohler, when you look your neighbors, especially children in your surroundings, how would you evaluate their body fitness, body condition, if you compare their way of living with your childhood? Because sometimes it seems that indeed there is an effect and that it starts here.
Well, I have sports people around, and that's why I see kids that do sports, and that makes me happy. But the statistics show that it's not as good in general population. Kids' obesity continues to grow, and obviously for the future this is not good. I can see that in villages, and the reason is that there is the competition of computers, computer games, cell phones, and even food. When you see, I'm even taken aback by the fact that supermarkets are full of people on Sundays, while Sunday should be a day off when people go out into the nature. They shouldn't go shopping. So to me, this is really surprising. Okay, and talking about kids who do sports, are they okay? Well, to me, the basis is starting with sports when you're young, and parents should serve as a role model. They should see that parents do some sports, and that's how they attract kids' attention, and that's where you create the foundation. My experience and the experience of my colleagues say the same. That's where you start loving sports, and parents should be a model. That's where we should start. And we should actually tell parents that they should start do sports because of their kids. Okay, so the minister, the secretary, and Mr. Kohler. Okay, don't expect me to criticize computer games, but I do catch Pokemons in Prague, and you can't do that from a car. You need to actually run around the city if you want to win. And I'm convinced that I have really got to know a lot of places around Prague thanks to Pokemons. I had to get to these places on foot. And I'm kind of joking, but anything that makes kids leave their home, whether they play computer games, watch TV, or do anything else, anything that makes them go outside is good. And there are different institutions that help to achieve this, and we should support these institutions, because unless the kids learn to love sports by the time they reach 10 years of age, it's kind of lost, and it's really hard to start this when they get older. Dr. Slobodnik, yes, I totally agree. It needs to be under the age of 10 or even 6. Before kids start going to school, usually kids just move around the way it is genetically given. But once they start going to school, they start, spending their day sitting on a chair. So you need to teach them the movement patterns in the spine cord by the time they reach 6 years of age. Now, we need to serve as role models. They copy 95% of what they see with their parents. So we should teach them what we want them to do. They just copy-paste what they see with their parents. Minister, if you should give a minister's advice, what kind of sports activities are the best and most healthy for anyone? And which of these activities do you personally do? Well, the most healthy activities, sports activities, are those that involves as many muscles as possible without overloading the joints. So scooters, kid scooters, bike, walking, that's especially not walking, when you actually involve the whole of your body, including arms, jogging. I mean, not jogging when you want to compete with professional athletes. I'm talking about jogging for the fun of jogging. And I think these are the best. Obviously, swimming, especially in countries where they have hot weather the whole year, swimming in lakes is good. But also any other type of sports activity is good. Also, like games such as hide and catch, or just kids games which they play with their mates outside, activities where you can run around regardless of whether you are overweight or not. It's about your fitness, about your ability to predict situations. So some kids' games kind of embrace all these different types of abilities, not just sports abilities, but also intellectual abilities, collective sports. That's what I'm talking about. It's really good. And we should support families that are ready to go out with their kids, whether they go biking, hiking, or anything else. And I think that's the key. And supporting families, what does that mean? How would you want to do that? You mean giving them time off work? No. I'll just suggest a detail. I got 4 kids. If you want to get a family ticket, you can't have 4 kids. You only can have 3. And my opinion is that the more kids you take out, the less you should pay. I've never come to understand why a family ticket only embraces 2 parents and 3 kids. Why can't we support families with more kids? Okay, thank you. Secretary, how about you? Well, just a small remark, because even doctors are listening. There is nothing worse than having a person lying around the whole day and then deciding to go and run a marathon. I've been talking to my colleague from Prague. They kind of made a survey. They picked a sample of 100 people who assigned to run a marathon, and they made medical cardiovascular screening among these people. And it turned out that 2/3 of these people had never, ever participated in any physical activity, and they were close to a heart attack. So you need to take small steps towards becoming a person involved in sports. So I think you need to take into account oxygen, your age, your abilities. So what I do personally is hiking. Every day I get up at 5 a.m. and I go for a walk, 3-4 kilometers, and then I go to work. And I use the special watch where I can count my steps, and I have got to a perfect shape, the perfect, pace adequate to my age. And I also do biking. Okay, thank you very much. Mr. Kohler, you play soccer, but what are the other sports activities which you are not old? So I mean the activities which you consider the most useful for you. Well, I'll start with the worst, and that's soccer. I try to avoid it because it really hurts. So my body really enjoys ice hockey. I play that with my former team members, and we all agree that it's the best for all of us. We feel really good. The sweat gets out, and the body doesn't hurt that much. And then paddle. That's something on halfway through tennis and squash. And I'm really happy to be part of a new center that'll be open soon, and I'll be in charge of the sports activities there, and I'll try to attract as many people as possible. It's a great sport for beginners, even those who don't do too much physical activity. So I hope to be able to make people involved and try out this new sport. So that's my personal goal for the future. See how Mr. Koller contributes to the prevention and health of the nation. One last question. Minister, as a member of the government, should sports be more supported financially from the state? And where would you aim this financial support? Well, obviously, it would be worth supporting kids' involvement in sports activities. I'm talking about kids between 10 and 15. There should be freely available sports grounds at school premises so that they could do anything, run around and do sports. Also, what we should support is sports activities which are performed in clubs, whether it's Scout, UNAC, or anything else. And then in terms of professional sports, there has been an increase in financial support. And this support is important because professional athletes represent our country. They increase our national self-confidence. And they are people who sacrifice a great part of their life. They don't talk about overtime. There is no labor code respected. They simply work and work hard. And there is this minor chance, fleeting chance of winning. And these people become models for generations that come after them, for young people who want to get involved in sports on a high performance level. Maybe they'll never become professional, but the problem is that the support to sports activities narrows down to the support of these professional teams, Olympic representation, and so on. This is important, but the fact whether the Czech soccer team will win a World Cup won't decrease the obesity among kids or increase their physical activity. And that's what we need to support, because that joy is impossible to share. But saying that will improve the health of the population, that's not true. So from this perspective, I cannot agree. So I think that Mr. Shabak and the sports agency do a really good job, and I'd like to really thank them. I don't know whether they are present or not, but the cooperation with the ministry and the National Health Council is really good. What I'd like to emphasize in terms of Prague, there's one thing I really like, and that's really improved. It's the network of cycling paths, which has really improved, and I can see many people using these paths, whether for cycling or roller skating, and I think that's really good. I go biking in Prague and around Prague, and if I compare the situation 20 years ago and now, is a huge difference. So my thumb up. And we can also give thumbs up to our debate. Our time is up. I thank the Vice Prime Minister of the Government of the Czech Republic and Minister of Health, Vlastimil Válek, State Secretary of the Ministry of Health of the Slovak Republic, Ladislav Svobodník, And many thanks for the time of Jan Koller. Thank you very much. Thank you, and we'll continue with our program, our agenda. We are going to hear the words of Ladislav Dušek, Professor Ladislav Dušek, head of the Institute of Medical Information and Statistics of the Czech Republic, who is going to provide data for what we've heard. So we are talking about the prevention of health risks and statistics in healthcare. Professor Dušek, the floor is yours.
Já moc děkuji za pozvání.
Thank you very much. I have a problem with standing because I've been very active in sports. I wanted to run 2,000 kilometers, and since I'm so very much charged in work, I'm only missing 460 kilometers to run, and my my objective will be reached, but standing like that, it's a bit problematic for me. So let me present my title as a choice, as a selection of data, and what is the basic platforms the prevention can count with in the Czech Republic, and what has happened as new during last 2 years. There are 3 basic pillars for the platform. This is the national health information and statistics. Thank you very much for your support. This is centralized the system of data with healthcare providers and with patients. We are able to identify people who do attend screening programs and who do not. But what is important to underline is that this reverse data, backward data. Besides that, there is a national screening data since 2022, which implements audits of current programs and opening the data. So a very quick invitation to this platform, and you can find a lot of open data and indicators of quality already mentioned here today. What is in red? This was something that was missing. I mean, managing real data, such as, for instance, if there is bleeding into stools in case of a woman, that it is interconnected. And this is what to be served through the new system, this. Also, what's new is, and I'm very happy I have lived up to experience it, there is a real cooperation with the Ministry of Health. The data is provided also on the trajectory of patients, which is a real good association. I will show you the money available. It's a lot of money for that. And also you can see what's the access rate, how accessible it is, for instance, for patients who are on brink of their oncological disease, which are many, many people. And I would be killed probably if I brought just one example. I brought several of them, so of course. This is the one that we can see even clients of residential facilities. We can see their health condition, and we can see, for instance, their vaccination rate. And this is a very detailed picture. We see that vaccination rate is 50% if they are in residential facilities, while it's only 20% if they are seniors living on their own. And there is still a lot of things to do. Also, that there are different qualities in residential facilities and so forth. And the last thing, the system already mentioned this, that should be fully launched starting next year. And there are some positives. I would stress out just 2: real-time sharing data mode that will make possible to share data on different examinations. We start with screenings and preventive examinations, but it can go further in depth. And the second novelty is EZ card that will again make possible a real-time management. Then there will be centralized records of vaccination that was implemented yesterday. It's a real-time system, a fully computerized system. A practitioner types a minimum of data into the platform. It's fully automized, and there is a transcription into EZ card for the patient. There is a shared record, among care providers, and this is the way we should continue. Starting January, February, we should have this format of screening examinations implemented at general practitioners as well. In my opinion, if we are in the situation we are, I mean, we are a biological species that for some unknown reason stopped reproducing itself, and there is a real risk of dying out. So supporting countermeasures is the only way to survive. This is a demographic structure of the population who sucks children. I'm one of them, terrible expression. And once it goes further, in those senior peaks, there will be the highest number of seniors in the whole modern time history of our population, and you can see the number of people who will be at the age of more than 85, and comparison between 2021 and 2040. And what is very much linked to it is economic issue, the problem that there will be, of course, declining number of taxpayers, while there will be increasing care costs, and since there will be lower and lower children, we have the reproduction hiatus gap, the biggest one since the 60s, so it will impact tax collection. It will influence the healthcare solidarity principle, social care solidarity principle, and the longer we will live, there will be more and more these consequences felt. What can we do with it? Usually only prevention is mentioned, and then very often, and I'm in that as well, it continues with tumors. So of course, there are chronic killers. I couldn't skip tumors, but if you look at this highly conservative prediction, what is the result? Plus 20% in 10 years, plus 68% in 10 years. The first was for diabetes, for the second for heart failure. It is something you get when you are highly polymorbid. Malign tumors, these predictions, I started with them many years ago, and these predictions tend to be very accurate, so it is increased by 27% in 10 years, and so on and so forth. I also took a CV. You can see that a Czech who doesn't have problems with cardiovascular system is not a typical Czech. So I went Professor Minek to consult this, and seems that there is between 20 and 30% of patients who are not compliant with possibilities of treatment, which is 1/4 of the population. And again, look at what are the predicted No, real increases, not predicted increases. It's terrible. So even heart failure prediction, if it goes this way, in 2040, there should be between 800 and 900,000 people with polymorbid condition and chronic heart failure symptom. So if there are people with these comorbidities, plus including diabetes and tumors, it would be parliamentary majority in a couple of years. I also took that this is the length of living in a healthy state, and for children 15 plus, there is an increase of mental diseases, and it's not due to the fact that the children would be, I don't know, spoiled or something like that. No. Even serious diagnoses such as schizophrenia, the incidence increases by 40% in last 10 years. Any way of prevention is 1,000 times better than treatment, and of course COVID has accelerated that, but it was not the only culprit. When you look at the curves, they started increasing since 2015, 2018, so before COVID. Then a short span of life in good health. This is not about, I don't know, competing with each other. It's a cruel reality. If you look at that, 4 major diseases, diabetes, oncology, CV, and strokes due to CV, look at increased sharp curves where people get to have these 2-3 diagnoses at the same time, and at a certain time 50% of the population suffer from that, and we will again die approximately at 85, but we will have bad health starting much earlier. If these 4 main morbidities are avoided, it would give us a totally different perspective. We are terribly obese as well. One would rather than not to believe it. Red is terrible. Even the orange or the yellow one is not good. So who is not obese is not a Czech anymore. If I take smoking and alcohol consumption, well, they are so increased that you may be surprised that you still meet people that would be sober walking in front of you on the pavement. So we are able to quantify effects of chronic diseases also on the social system, and heart failure would be a quick model how to explain it. Already by now there are 374,000 patients, which is a size of a smaller town. When I looked at further data at the age of 20 to 64, out of 52,000 people who normally should be healthy and good taxpayers, only 54% are indeed, they work and they pay taxes. So invalidity, disability in Red Square, disability pension, 30,000 people, 25%. And if somebody told me 5 years ago I would write such a picture, I would call him a fool. We've never had these results. We've never had these links between both social and health data. Red color, bad. Heart failure in that age interval. Those who still work, we can see what are the work disabilities. They are not trivial. They are very often polymorbid. These are disability and old age patient collected by patients with heart failure in 2023 according to the age. You have old age pension in blue and disability pensions in different colors. The presentation will be soon available. Whatever screening can be done, we have it. In the Czech Republic, we have so-called population-based screening for prostate carcinoma.
Here is the link to the website, but I don't want to take up any more of your time. But in terms of breast cancer screening, there's been an early detection of 62,000 cancers. Can you imagine the curve without the screening? Most of these women have kids which are small. Cervical cancer screening, also a high figure. And look at colon cancer. Over the time it's been organized, the mortality has gone down by 48%. They've detected 150,000 adenomas and tumors in an early stage, which is awesome. So the detection of adenomas and, let's say, potential polyps is 9,300. Imagine a third of these would turn into tumors. So the benefit is tremendous. So what is the problem? Well, the participation of people is definitely not great. I don't want to get satisfied with what we've heard. To me, 60% is not enough. We are getting close to 70% in breast cancer screening, but it's only 70%. And every year we get 1,600 tumors diagnosed in stage 3, and imagine mortality. So we can save tens of thousands of women, and thank God for all these. But there are still the remaining 30%. And I'm not talking about colon cancer screening, where the coverage by screening is only 30%. Okay, if you count in all the different kinds of colonoscopy, it's over 40%, but still not enough. Okay. Here you can see the incidence and mortality of colon cancer. But what is awesome is that if you go for colonoscopy, you remove the polyps and you simply prevent the occurrence of the disease. But look at this, 50% plus don't come for the screening, and those are the people that occur in the red part of the diagram. Now, this is something we need to emphasize. Will a person will a person go for this screening? And if they choose it, will they come for colonoscopy? If they do, they won't even be shown in this table because they simply don't have cancer. So if you detect the cancer early, you can simply prevent it. Stage 4 cancer, that's where people simply die. Stage 3, that's the heroism of our healthcare system, because here the survival rates are really good. Every year there are 3,500 tumors which are detected late. So here we need to improve. Now, a taste of money. I'm not an expert. It's just counted. based on the data from health insurance companies. Every year, there are late detections in the rank of 3,500. Look at stage 3 and 4. Here, you can see the annual cost from public health insurance, which amount to 720 million. In stage 3, the cost is 2.6 billion, which is higher than stage 4 because there is high mortality. And imagine this cost wouldn't need to exist because you could eliminate this kind of cancer. And all this comes from public health insurance. Now, how much do they pay for just a single disease with late detection, stage 3 plus colon cancer? Disability pensions, and this is just a prevalence picture, so there are tumors detected 10 years ago, and we are looking at the payments from the social system each year. It's not totally exact, there is no reference period, but I just wanted to show you some figures, and thank God we got these figures. We want to make them available to the public society. It's 2.1 billion a year, and this needs to be added to the previous 2.6 billion, and this is just for one single type of disease. I mean, prevention has many different shapes, including effective organization, and this includes the screening for colorectal tumors. This screening is totally effective and cost-saving. Our population has 10 million people, and there is nothing to discover. This system needs to be well implemented, and that's what I'd like to say. My personal appeal, disease management, that's the key word here. It's a part and parcel of an effective preventative strategy of the state. Let me just show you two or three pictures. Do we manage the disease management discipline? You've seen the survival rates for colorectal cancer. The survival rates show that the patient can live until they get another tumor. And we can see that there is a 20% detection that is 1,600 cases. So these are tumors in patients who have already had a tumor, and this is a secondary tumor. So these are people who are well aware of the risk. And again, we only detect these colorectal tumors in 50% of the cases, and yet these patients had a previous tumor. How come we can detect 50% stage 3 tumors in these patients? How come? Because these are people who come, who are afraid, so they are coming for some sort of screening, and yet they come too late, or they are detected too late. So here is a picture showing people who are in the right age to be subject to colonoscopy, and there are only 20% of people in this age group who come for this screening, and yet they are observed, screened by a GP. They go to dispensary checkups, and all of a sudden there is a melanoma they are faced with, and it's stage 4. So it's something that you don't want to die from. And since 2015, there's been 20,000 tumors in these people, and 55% of these tumors are detected in stage 3. So you'll make their life longer, and then they'll die of a really expensive disease which could have been prevented and detected. And when we, kind of leave the moms and GPs for young people and adolescents, all of a sudden the attendance at regular checkups goes down to about 50%. When you're 20 years old, you're perfectly healthy, and you simply don't go to see your GP. And this trend continues. And the reason is that these people go to various specialist institutes, and even if my data are wrong, which is suggested by Mr. Shonka, even if the figures were 10% better, it's still bad. So this is a challenge, disease management. Hopefully I didn't totally spoil your day. It's just a challenge for the future. Thank you.
Děkuji, pane profesor.
Thank you, Professor, for this excellent lecture. And I hope that when we meet for a conference in 30 years and you'll be there as an old man, you won't need to say, this is what I've told you. So the medical and social part represent a great challenge. Nobody can say they don't have the data. We know where the problem is. We know what the solution is. We only need to create more robust teams to analyze the situation, because we don't really manage to do that. And that's why I'm glad I noticed Professor Dlouhý at the conference here, because we need to create a database so that we can start counting the cost. It's about economics, and the figures are scary. The money coming from health insurance is equal to the money that comes from the social sphere. And if you consider that many of the diseases could have been prevented, the volume of money is just giant. So unless we do something, the development will really be scary in the future. Thank you very much, Professor. This is the end of the first part of this conference. Now there will be a break until 11:45, and then I'll give the floor to a number of experts from the different fields, and we're going to talk about good practice and effective preventive measures. Thank you.
Ladies and gentlemen, we will continue with the second panel of our conference, Economics of Prevention. The panel is being composed of experts, mostly physicians, representing different disciplines of medicine and health care. I would say representing the most important spheres where our prevention and attention should be focused on. There will be, first round, your general impression of your sector, what instruments do you consider the most effective for your specialization, and in the second round you would be invited to give your personal recommendation for possible changes. So let me welcome first Professor Dr. Martin Haluzík, President of the Czech Obesitological Society, diabetologist and obesitologist. Hello. Professor Andrzej Mariusz Fal, President of the Polish Society for Public Health, Head of the Allergy and Pulmonary Diseases Clinic of the National Institute of Medicine in Poland. Dr. Martin Holý, psychiatrist and sexologist, the Center for Mental Rehabilitation in Beroun. Hello. Also, Associate Professor Dr. Jiří Votruba, pulmonary specialist and internist, head of the Clinic of Tuberculosis and Respiratory Diseases of General University Hospital. Professor Petr Neužil, head of the Cardiology Department of the Nahomolce Hospital. Hello. And now we will try our online connection, whether we are in connection with Mr. Daniel Dražan, member of the Committee of the Czech Vaccinological Society, General Practitioner for Children and Adolescents. Yes, we are online. Sorry for not being with you in person, just virtually. Sure. Yes, we know that there are different infections around us, including COVID, but we are very happy that we could welcome you at least virtually. Also, Petr Šonka, chairman of the Association of General Practitioners of the Czech Republic, and also advisor to the Prime Minister of the Czech Republic, addiction expert Mr. Jindřich Vobořil. Hello to you as well. As I already indicated, in the first round of our contributions, we will describe a general situation in terms of prevention in different sectors, what are tools and mechanisms available, and the second round will be your recommendations. Professor Haluzík, do you have any examples of good practice in your specialization? What tools available do you consider as the most effective ones? Thank you very much for the invitation and for the honor to speak in the first place, which doesn't happen to obesitologists very often, but probably it's due to the fact that indeed the number of obese patients is going up. I would dare to say that perhaps what we did manage to do properly is the National Obesitology Program, which is now in commenting procedure at the Ministry of Health. It should cover all this topic from prevention up to treatment itself. And allow me to say that we have very good preliminary results, especially in prevention programs for children, because this is the right time when to start with prevention. As a matter of fact, in this first preliminary program, and it's very good that Dr. Šonka is here, we will contact the Association of General Practitioners in the Czech Republic, because these are the most important experts that could help. And also what we do manage to do quite well is improving education, proactive access of the Ministry of Health, and cooperation with the National Institute of Health. These are the things that cannot be implemented immediately, but we progress. And also we have very good drugs still not reimbursed. There are drugs that also compensate diabetes. Some of them reduce cardiovascular complications or even renal complications. We do not have yet reimbursement for those drugs, so it must be very closely debated what patients should be reimbursed and where reimbursement would be appropriate and helpful. We spoke about exercise. Is it a part of your program, especially in terms of children? For sure, we have it there. Indeed, this is where prevention should start. We have two pediatrists among us who are focused on this particular sphere. We already opened the debates on how approach delivered by schools should be modified, because many children do not get the right examples in their families. So if schools apply good approach, it could be a good completion, so that children are properly educated and brought to exercises. You are at an international conference. So what's the position of the Czech Republic? Are we champions? If evaluated by prevalence, I have to say that unfortunately we do not have exact prevalence data. Even insurance health companies do not have it. But we are not among the worst ones. We are in the last quarter, in terms of children, the situation is perhaps slightly worse than in adults. COVID pandemic was something that contributed very much to this negative situation. And as Americans tend to say, there's a large space for improvement. Do we have any exact indicators for evaluation, or will the discussion be rather of general character? It will be rather of general character, but we did learn already that what we have to evaluate is, among other things, indicators of future prevalence. These are indicators on general and specific factors closely connected with obesity. There's also a certain proposal how pharmacotherapy could work, but it's really just the initial stage. We have to discuss with other sectors, specifically with Ministry of Health. And Professor, last question to you. Drugs in diabetology usually didn't work very much, or were rather disputable, while now seems that there are new drugs that look very promising. Do you think pharmacology in this respect could advance up to preventive medicine level? Yes, indeed. In terms of effects, drugs seem very effective, not so much from the point of view of their price, but as a matter of fact, drugs are rather help enabling a patient to change his or her living way. It doesn't treat obesity. It's just an instrument, a help. It can change the person's way of living. I know that Professor Nauzel will relate to that. They reduce cardiovascular complications and therefore mortality rate. We have already the first data that both mortality and CV complications are reduced. I do not want to take much of the time, but in my opinion, obesity, first of thing, it is an illness, which is good that it's been recognized. The second thing, there are those of us who need drugs. But I would underline the role of a nutritionist, nutritional therapist, because drugs can start the process, but nutritional therapists must complete the process. So thank you very much for the drugs, but they are not everything. And thank you for all your effort, because you do the work very well. Thank you, Professor. And now Professor Fall, who can look at the prevention topic through the perspective of his specialization. He is the president of the Polish Society for Public Health, so he can also speak about a larger context. What are examples in terms of prevention and public health? What instruments or procedures do you consider most effective ones?
First of all, good morning once again, and thank you for having invited me here. It's a big pleasure and honor to speak this morning. Well, first of all, my first specialty is allergist. So I'm the glad one, because 65% of the total population at some point will show more or less developed allergic syndrome. So I'll have enough patients, and also my students and my assistants will have enough patients for their entire lives. My second specialty is pulmonary medicine, which is not that easy, because we have a huge increase, as in cardiology, of lethal diseases, especially chronic obstructive pulmonary disease, especially the lung cancers, I should use plural here. And we have these environmental factors that we really cannot, as patients, do a lot about, because, well, the environment has been destroyed by the human being, but in the past hundreds of years, not we. But secondly, we have smoking and other things that go into the lifestyle. So the lifestyle is the most powerful tool to prevent the chronic diseases. I've been listening very carefully to the morning session, and I really admire that every of the speakers mentioned, at least for a while, education. But very shortly after that, they went already to secondary prevention, because screening and trying to help out those who are already obese or who have already this or another disease, it's not prevention, it's not primary prevention anymore. This is prevention, secondary prevention, tertiary prevention, but this is not the primary prevention. So I would bet, as third specialty, public health, I would say that starting with the health education, building health awareness very, very early, first at home, even before kids go to school, but then after a real project, a real subject that they need to be taught at school, as math or history or geographics, the healthy living. And this is the only thing, in my opinion, to really overcome the epidemics of chronic diseases that we are facing now, that we are in now, not only facing. Because when you look at those who refuse vaccination, well, they refuse vaccination because they have no health literacy, so they're not educated. When you look at those who, don't go for screening procedure, for screening project, of which Mr. Secretary and Mr. Minister have been speaking this morning, they do not go to these procedures because they are not aware that they should. So they're smoking cigarettes, they're drinking extensively, they're getting obese. All this because they have no awareness, no knowledge how much will it destroy their health. It's not only destroy their health, it will make them live shorter. But, we tend not to tell it to the people so directly. If I told my patient, you smoke this cigarette, you die tomorrow, he would reconsider smoking this cigarette. But when I tell him, when you keep smoking so much as you do now, you'll die earlier. Doesn't make much sense to him, because he has the background of the principle health awareness. Sorry, it was too long. I'm sorry.
Professor, we are talking a lot about kids' education. Is it worth educating also adults? Is there any meaning to that? Telling adult people how to live healthily, do they actually react to that?
That's a very good question. As I said, if I tell a patient that you smoke this cigarette and this is your last one, then he believes me. If I say it's going to happen in many years, the belief is not so strong anymore. But look, we should educate people at every age. I've been talking about the primary prevention, so health education, secondary prevention, which is early screening and early treatment of disease, and tertiary prevention, which is real treatment of the diseases and harm reduction. And I think that we need in Europe, well, we will not have a common healthcare for the next 50 years at least, if any time. But I think that we at least should to have a common way, common path, showing which procedures are the good ones with evidence-based medicine and which are not. Now we know that running and healthy living, yes, this is the procedure, if we can call it a procedure, is a good one. So let's look at different ones. Is drinking too much really so bad? Is harm reduction a good procedure? Well, let's put some effort on verifying this. Let's have some common European attitude to those things that we believe that influence the health of our societies. It's up to us what we decide, but we need to decide to do it together because, well, for me it's very illogical that there are countries in Europe who, well, let's say, implement the harm reduction in drinking, smoking, or sugar, whatever, reduce harm of some unhealthy compounds. And there are other countries, just neighboring countries from the same European Union who say, no, this doesn't make much sense. You shouldn't do that. So let's have at least a common path that we follow. Of course, always regional differences will exist. That's why we're different. But we need to have some real path. Let me repeat the word once again.
Thank you. One more question. Do you have an examples where the contribution, the benefit of a preventative program in public health is quite clear and it's good for the economy and for public health as well, obviously?
Absolutely. Looking at the Polish programs, I can give two examples. One of them is the breast cancer. I think that the same experience will have all the countries, including Czechia and Slovakia. Now we can say that the breast cancer becomes more a chronic disease than a little neoplasmatic disease. Only because we have introduced the prevention program, only because we have introduced, self-examination, so early detection and good treatment, and after treatment consultation. So we have a chronic and lifelong, I would say, support for the patient. And this caused that from mounting high numbers of women dying of breast cancers, now we're saying that the breast cancer doesn't have to be a lethal condition whatsoever. This is one thing. The second is, less spectacular, because even though I started saying that 65% of the general population of the globe at some point will have allergic disease or at least allergic symptoms, but allergy is not lethal. Well, in some exceptions, as bee venom and several food allergies, but we introduced locally in several regions of Poland the program of reducing exposure to chemical substances and taking the children out to the nature, because we tendency to closing children in a sterile environment. And this works. Actually, the first groups that we are observing now for over 10 years have much less allergies to common allergens, of course, than those who were not in this program. I mean, it's not the ultimate proof. It's not evidence-based medicine category A yet. But, this is something that shows some hope for the future.
Thank you very much. Can you actually look up that program? The program you were talking about at the end, because this is really interesting about the allergies. Is that available on the internet?
Yes, actually, it's at the page of the Polish Federation of Allergy.
Dobře, děkuji velice pěkně pro tuto chvíli, pane.
Thank you very much, Professor. And now we'll open up the topic of mental health together with Dr. Holly. You have probably heard Professor Duszek's presentation, and the figures sounded really scary. Maybe we could say in the beginning, or ask, whether these figures correspond to your experience from practice. Is the situation really so serious? What do you think? Well, thank you very much for having mental health at the level of all the other disciplines, although we don't have any hemoglobin and BMI, which would help us to select out the population we should focus on. I mean, we have some tools, but they are frequently not as simple as we'd like them to be. In terms of adolescents, the growth in mental health disorders is enormous, and you can see that in the capacity. And it's not unexceptional for us when we try to search for a children's psychologist, psychiatrist. The waiting periods are beyond the horizon of the event itself, because there are waiting times of 6 to 8 months, and in the meantime, it's either too late or they find another solution, which often means that there are other risky scenarios which are created in the meantime. So yes, the figures are in line with the reality. Thank you. You said that mental health does not comply with these beautiful measurable parameters which can be easily assessed. But yet, do you have any sort of good practice in the area of mental health and prevention? Can you give any examples? Most of mental disorders, or a great part of mental disorders, which creates the greatest burden, which is anxiety and depressive symptoms and diagnosis, are quite easily preventable as long as the programs are well set up. So, to give you a few figures, WHO says that anxiety and depression brings or account for 12 billion lost work days. So this is just to show the economic impact on the welfare of the society. Now, we are able by 1/5 or 1/3 reduce or delay the symptoms using preventative activities based on community behavioral therapy, which is shown by the meta-analysis of the studies that have been done. So we need to create evidence-based programs. In the Czech Republic, we have preventative programs based on social care system and the school system in the area of mental health. Quite often, they stem or they are supported by enthusiastic groups and influential people. Frequently, they are preventative programs at schools which try to destigmatize this problem. They try to talk about mental disorders and possibly work on something that we could call emotional literacy, so that these people can identify their emotions and then select out those who need additional care. So there are various types of programs which are focused on the literacy of school children and specific assistance and study aimed at children and adolescents with problems in mental health. Okay, when somebody comes to see a psychiatrist, he or she comes for a treatment. So, thinking about prevention, whose roles is it in the health system? Is it GPs or doctors? And what kind of cooperation do you have together? Well, we cooperate well under the limits given by the capacity. I think that together with Dr. Shonka, we know that the line of the screening and the transfer of patients at risk is well set up, but usually there is the problem with the disease management, which was brought up by Professor Duszek. So it's up to the patient to find therapy. So the highway of the person with a mental disorder is much more difficult than the pathway of those who don't suffer from any medical disorder.
There is no health without mental health. And when we look at symptoms of slight depression or anxiety, often connected with despair and pessimist life perspective or outlook, it's difficult to make any prevention already at that low level, because there is a basic argument missing why such effort should be deployed. Please describe us as well situation of adolescents, young people who spend their life very much virtually with electronic devices. There are different disputes as to whether it does have an effect or not on their life. But what I'm rather interested in is whether it's a group that necessitates some specific programs to be reimbursed by health insurance companies, for instance, whether the situation gets serious enough for that. Because it seems that there are many young people who get into uncertainty situation, and sometimes they are even suicidal. We've been living in the world as it exists, so we cannot change the fact that there are cell phones, we cannot change that there are algorithms governing functioning of those electronic devices. We cannot change the fact that both parents scroll down electronic devices similar way as their children, only the difference is probably in targeted applications. So this is our reality. We cannot or hardly can change it. And therefore, to forbid these things is obviously not a good way. On the other hand, activities going in the direction of trying to be at least partially independent of those virtual devices, some detoxification programs. This is something recommendable, and it appears in the world literature that, yes, indeed, we could use this space suddenly freed up for prevention programs, for cognitive behavioral therapy, for instance, that can be very well applied in distant mode, and therefore access to it is larger. So in taking use of the space of the existing virtual space for beneficial applications, for beneficial programs could be a way. Yes, so getting into this virtual world through a back door and deploy some positive things in there. Yeah, exactly. Let's get to respiratory diseases. Associate Professor Dr. Jiří Votruba, could you evaluate the current situation and the the quality of existing tools, which one are beneficial in your evaluation. Thank you very much for the invitation, for the question. It's an honor for me to be here. In our discipline, we used to be rather nihilists. Respiratory medicine used to be connected with diseases hardly treatable. With exception of asthma, we were rather not performing in the field, while throughout the last 30 years, the situation changed dramatically. Not only we began screening of pulmonary cancer, which we ended up in 2018 by the U.S. model, and it was it turned out that low-dose CT was a very beneficial measure for survival of those oncological patients. But there were other diseases such as pulmonary fibrosis, chronic obstructive pulmonary disease. These are suddenly treatable diseases, which is a great change. How to use the instruments, we could speak about it for long. The patient's journey, we could speak about that as well. It's not satisfactory yet, and it could be certainly improved. When you look at the array of instruments you have when working with a patient, so that his or her behavior changes in terms of more prevention, reactions of people, maybe of course very individuals. There are people who are highly resistant to any recommendations. You should discern several things. Patient's scheme of education depends on his/her education, his/her own initiative, whether the person wants to be examined, whether there is this ostrich hat phenomena. I mean, whether the person wants to know at all whether he/she has a tumor, whether he/she wants to quit smoking. These are the things that, of course, depend on the social, economic, family background. There may be different inputs that should be treated probably even more by us. Then there are questions relating to the system. There must be a health care specialist educated in diagnosing and treating illnesses. Sometimes that link is missing as well. Or technical background. At last we started with pulmonary cancer screening. We have a screening of pulmonary nodules. We still do not have instruments. We do not have instruments for pulmonary bronchology yet. We need to be able to get more pulmonary nodules obvious, to identify them and to diagnose them. We cannot identify them and pay for the diagnosis, which is rather incredible. So there are things that can be changed both on side of the patient and of the system. Does it mean anything for your patients when their lung oncology is diagnosed, whether it has any impact on change of their behaviors? This is enormously stigmatizing diagnosis. In most of our patients, it equals death verdict. Although we change the image of it, but in any case, it's an enormously serious piece of information. At the moment he or she gets the diagnosis, usually the person is able to change anything, including smoking habit. That can be fully compared to cocaine dependence habit. Suddenly, at such a moment, they are willing to change this habit as well, to get rid of it. Thank you. Would you have any example of effect on prevention in your sector on the economics? Potential effect on economics of the health system is enormous. We can see that one day of pulmonary oncology hospital day is enormously costly, while an early surgery costs just a tiny part of the amount. So you can save a lot of money if, for instance, out of 6,000 lung cancer patients, just 150 are caught in our preventive screenings. That would mean a lot of saved money for the health care system. Thank you very much. And now I would address Professor Dr. Petr Neužil with similar questions. What's the situation? What are the tools available, and which ones are the most effective? But I know for sure that our guest prepared also a short video as a certain little gift to this conference. It's ready. My presentation is a simple one. It's been already presented, in fact, by Professor Dušek, because he spoke about heart failure. He spoke about all those stressing aspects that made us concerned. So, best evidence, the practice of measures applying influencing the practice. I would say conscious of a patient. A patient, 51 years old, former football player. He spoke nicely about sports and exercises, movements. He didn't have any comorbidities. However, he suffered from a long-term ventricle fibrillation. For 3 times there was an attempt at stopping the ventricular fibrillation through a cardio stimulation method, a method that is in principle able to stop the arrhythmia and can treat the patient, cure the patient. He didn't have any risk of stroke, and he was on a certain drug regime. Since he was very active, could you please change the slides? Since he was very active, he agreed in 2021 with the intervention done on him. It was a brand new method we developed ourselves. It was pulse arrhythmia intervention, that is catheter and picture of the intervention. It's beneficial due to the fact that an intervention that used to last several hours now lasts just less than half an hour, and it's long-term efficient. So after he has consented with this technology being applied on him, you know that we are very much focused on that method with a colleague of mine from the U.S., Professor Friday. You can see the numbers of patients. So we applied the methods already on. The patient was brave enough to consent to the intervention in September 2021, and since that information being carried out, we didn't see any single arrhythmia of his heart. He didn't need any more drugs, and so he was completely prevented from any chance of getting CV failure. Another case study, number 2. This is a woman aged 81, former singer. On the previous regime, she was forbidden as a singer for some time. She came with acute infarction in 2015. The illness went in a very complicated way. What was important was that she had been a heavy smoker since her age of 17. And as my predecessor said, it's sometimes very difficult to dissuade smokers from smoking. We are not able somehow to penalize them so that it's financially interesting for them to stop smoking. But in 2015, she shifted to complete vaping. She quit traditional cigarettes. She didn't tolerate some drugs, so we could administer only lower doses of traditional drugs. We made control checks in 2017 and control angiography of arteries, and now in September, catheterization was done with minimum non-invasive treatment. She hasn't been smoking for vaping since 7 years, and we found out that there was a slight regression of atherosclerosis. Theoretically, if we didn't bet, I don't know what is being prepared in terms of law legislation, but we could reach that 5.6% of Swedish population still smoke standard cigarettes. In our country, it's 25% or even more.
But I think that the goal is to explain the positives of alternative ways of smoking. Of course, you shouldn't give it to children. I definitely don't support that. But the curve should go from classical cigarettes, maybe cigars, to the alternative ways. So that's my suggestion for clinical practice. I'm not a clinical cardiologist involved in prevention, but we need to realize that the good clinical practice can lead to quality secondary prevention, and also in terms of secondary prevention of obesity, there is a number of modern therapies, medicines, which have a really good impact on obesity. And I would say that if I was a bariatric surgeon, I would be afraid I might lose my clinical practice. Thank you. Thank you, Professor. A reaction from Assistant Professor. Let me react to the last slide. The ideal situation would be not smoking and not drinking. Yes, that's what I said. It's not good if you smoke. Of course. And we need to admit that whether heated tobacco or e-cigarettes have a 5 to 7% of carcinogenic load. This is confirmed, proved, and also the FDA supports it. So it would be good for us to have to be able to use these mechanisms, but again, there is this opinion that non-smoking is the only alternative, but we know that there is a number of people that are unable to stop smoking utterly. But I agree that our goal is to have non-smokers. Yes, we agree on that. And prevention tailored to your patient according to his or her needs and preferences is good. Thank you very much, Professor. And there will definitely be room for questions. And it was just right. Thank you, Professor. Thank you. We'll definitely give room for questions, but now I'd like to give the floor to Dr. Drashan, who is online. Hello, can you hear us? Yes, I can hear you and see to the perfection. There are about 6 screens, so we can see you very well. Our topic is vaccination. And I'd like to ask, which types of vaccination are well set up in the Czech Republic? The rates of vaccination are good, and where are the problems? Could you tell us also the situation in children and adults in a brief form, because I know you know a lot? Yes, there are many things to say, but I need to be really skeptical and critical of our vaccination, because from the perspective of prevention of infectious diseases in terms of vaccination, we are not well vaccinated. The vaccination rates are good for diseases where vaccination is free, but there are also other types of infectious diseases, but here it is not compulsory, although it's still free. And here it becomes more complicated, such as HPV infections, meningococcus infections, and things like that. But still, the figures are quite well, but not perfect. And then there are infectious diseases where the vaccination has been used for dozens of years in some countries, but we are unable to even get close to the figures, and we are lagging behind in the rank of tens of years. And just to be specific, in terms of children and adults, I'm talking about rotavirus infections and smallpox. And many of these patients end up in hospitals, and many people say that chickenpox is something you should go through, and then you'll get the right, way of dealing with the disease. Professor Dušek has shown us some figures. The total population has been vaccinated at a level of 5%, and it's been like that for 20%. Children at risk categories and pregnant women are not vaccinated in some categories at all. So there are huge reserves. And talking about pregnant women, here I think that we really are lagging behind, and we should really appreciate any woman that is pregnant, and we should provide them with information, and we should provide them with vaccination which protects not only them but also the unborn children. Another example I'd like to give. Just by coincidence, my colleague has sent me a poster which he saw in England. It's a huge poster which you can see at bus stops. They deal with CBC, and here I think the Czech Vaccinology Society should take the example, but he didn't really realize that neither this society or any other society has any funds. If we bought a poster of this sort, we could afford another one in 3 years' time. So there is a problem not only in information sharing, but also in the financial coverage. So there is a huge way we need, and many steps we need to take forward. And it's good, there is work to do, but we need to do it fast. Thank you, Doctor. Looking at the causes of what you said, we have always thought that the Czech Republic has had a tradition of vaccination, and it's the situation, according to what you said, is shameful. So where is the cause? Is it about money, or about the fact that vaccination does not have the kind of reputation it used to have? The the anti-vax campaigns have actually had an impact. So why is it a problem to say we are going to vaccinate a pregnant woman? Because obviously there is this huge public debate about why do you want vaccinate pregnant women. So do you think it should be the state talking about that? And who should give the money which is missing? Is it going to come by itself, or do we need to join strands, and where should it come from? Well, we've given up our fight against disinformation, misinformation, and misinformation is winning. And we don't even put in our mental strength or the economic means. So here are the ways we need to focus on. Maybe commercials on TV or posters, but usually these are funded by pharmaceutical societies, and that's what people don't trust. We don't have the awareness, which also costs money, and we don't have the financial coverage. I'm not an economist to tell you what it would cost, but it is obvious that we'd save billion of Czech crowns if we vaccinated people against flu. Because it's not only about those who end up in hospitals, but also about those who have little kids and they simply don't go to work and end up on sick leave, and that costs money. So maybe the healthcare system will not save money itself, but there will be other savings in other sectors. So it's about kind of shuffling the money around and giving them to the sector that needs it, because you'll know that there will be costs saved in another sector or sectors. So hopefully this will work. But, Sarah, we've been talking about that for years, and there's been no progress achieved. And yet it seems that we are close to achieving the goal. Everybody understands, everybody supports the idea, and then at the end of the day, nothing. Going back to flu, would it help if there was a higher number of possibilities or places where you could get vaccination? Different professions or pharmacies where you could get the vaccine. Would that help? Well, there's a huge debate about that. I don't think this is a crucial step. To me, it's about full coverage, full funding for everyone, and not only for elderly people and selected morbidities. But obviously, every small step would be good, so I'm not totally against it. The discussion is going on. Some people are totally against it. Others say it would be good. In my opinion, it would be good. For some diseases, it would be too complicated because you need to have some sort of education for that. But in terms of flu or COVID, I think it wouldn't do any harm. And in fact, it might actually help. But I don't think this is primordial. And in terms of adults, what's the problem? Flu or other? Can you name other diseases? Well, for example, we've been through an epidemic of diphtheria, and whooping cough, and pertussis. And there's been many people suffering from pertussis, and the epidemic is slowly leaving, and the debate is kind of over, so it hasn't moved any much forward. And some vaccines, of course, are really expensive. Vaccination against waist herpes and things like that, that's for discussion. But we need to tell people that there is a possibility of vaccination. On the other hand, looking in other countries, if the regulation authority authorizes a vaccination, immediately, whether it's in the US or in England, they start discussing it. They obviously consider the funding involved, but it gets to the people very soon, whereas in the Czech Republic it takes tens of years, dozens of years. Thank you. You can think about the recommendation which I'll ask you for in the end. Now, a question. Are we actually lacking or missing a stronger voice in terms of a systemic change which could be decided? But please think about it for later on. Thank you very much for now. So this was a really critical perspective on vaccination. I'm glad we heard it. But we really need to think about how to change the situation, because the discussion has been here for a long time. And all this leads us to GPs. I'm not sure whether the medical doctor here will agree with me, but the question is similar for everyone. What are your possibilities in terms of prevention in your medical practice, and what are the most efficient ways? And also, to what extent can you use modern technologies? Thank you very much for your question.
Thank you for the question. Yes, indeed, we are a place where different ways are concluding together. We have more than 5,000 GPs, and 1 million of Czechs do not have their GP, which is not having access to primary care. And this is something that should be important, a nightmare, an important nightmare for all strategists and planners of the healthcare system. So we cannot speak about general prevention, general preventive programs. We have a decree on preventive examinations, but in the Czech Republic, but this is not something that could be called general standard. In Europe, there is a system of preventive examinations every 2 years. You have the right to it. If you speak about it to Scandinavian people, they can hardly believe it, because they are not so much focused on prevention. And still, I think that we are properly focused on prevention. We have a good basis, and we should develop it further. You heard Professor Dušek. We managed to carry out prevention programs by something as 50%. I would say that since I am an elderly physician, I would rather agree with our minister that we cannot expect a higher participation in preventive examination than is the one in elections. This is the right guess, I would say. And it's not meant negatively. We have a certain percent of population affected. In the rest, there is 50% participation in preventive programs. Last year, reimbursement of preventive examinations was changed. That should result in invitations for those examinations be more frequent, because it will be economically rewarding to GPs, so they re-evaluated their time spent in the ambulance, that it's better worth it now for them to dedicate some time to prevention as well. So if we manage to turn at least the part of preventive examinations in identification of diagnosis, it would be certainly a very good economic return as well. What should be the structure? What should be the shape of preventive examinations? OECD sometimes criticize us that we work very little with individual risks of a given person, which doesn't show to disease management in terms of chronic diseases. There is a space for improvement, that's for sure, and we take some steps in this direction. In terms of technologies, modern technologies used for preventive examinations, I do not see any effective modern technology to be used in ambulances of GPs, but as a matter of fact, a lot is worked with not a medical technology, but with something that will change time management in ambulances. This is so-called flow management. This is a certain system how to manage patients' wishes and needs, how to manage communication channels, ambulance or GP and patient. So this bilateral communication to be managed in a flow way, and that is more effective. When my sister used to take a day off on Monday, for instance, because she was sent for a visual examination in a faculty hospital in our district city, and she was told there that she couldn't be examined because she had to wait and the day list was already full. So this is something that should not exist anymore now. Would you like to react? Of course, I wouldn't like to speak into your excellency. Everyone knows that my sector is a bit different, but we also have several ambulances of GPs. We bought all apparatuses of BOCT, and what is it, please? BOCT is point of care diagnostics. This is a set of laboratory examinations that at the moment the patient comes, I get immediately some initial information I can use further for clinically decision-making process. This is, in my view, something very basic, something that is in a daily use by doctors. Of course, we use those in our practice, but this is not something new. What about education, doctor? That could be education, that could be done even in a remote way. I know that a contact patient and physician is the very basis, but what Dr. Holly spoke about, I mean, to make some things more playful. People have their cell phones today, and they can do so many actions on them, such as, for instance, checking their own health condition. Sure, this is something to be thought about in the future, for sure, but I'm afraid we are not far enough yet. In GP's practice, there's absolutely no time slot for education. If any intervention is carried out, it's through medicines, drugs. You instruct the patient about a healthy living way, I mean, quit smoking and so on and so forth, but time slot is extremely minimum. And whenever we wanted to prolong it, payers of our care sort of disputed that, saying that it's just not measurable, that it could cost a lot of money. So there is practically no space in our everyday practice to educate our patients when I speak about physicians and also when I speak about nurses. If some applications are used, I can imagine the role of AI that is getting bigger and bigger, but this is B and C, and we still do not have A. Okay, doctor, we spoke about the screenings. What's your view of them from GP's point of view? What are the limits? What are the challenges there? What makes you upset with screening programs? There's a big boom of them now. Practically, besides cervical carcinoma, all other screenings are done by GPs. As a matter of fact, even GP should check up whether other screenings were underwent by a patient, and if not, invite a person to do that. Colorectal screening, and participation of the population in it, the result is phenomenal, and it's unprecedented in Europe, and it's very much to be boasted with by GPs. And there are many people who have underwent, I don't know, a colorectal screening because of some illness some time ago, 10 years ago, so they do not go for it anymore. But there is no age limit, and we have a polymorbid 85-year-old patient that has CV complications. To make a colorectal screening is rather problematic. Doctors know that, so such a person will not be routinely exposed to it. However, it should be always considered individually. And what we have heard recently, that screenings could be done in pharmacies, I think that would be a very disruptive measure. I think it should be definitely done by GP and in the ambulance of a GP, because the patient must be then guided through the system, so that if there is a positive result, the person must be guided as soon as possible to the specialists and to the place where the treatment will begin. So I think that such a change would be rather detrimental to the system. And one more thing, Professor Dušek would not be happy with it, probably. We should start looking at screenings rationally. There have been many of them. Aneurysma screening will be launched next year, and there are more and more screenings, but I think GPs have certain limits. And when I hear about deteriorated hearing ability in seniors, I think this is rather too much. I can recognize a patient with a deteriorated hearing capability without any necessary screening before that. It's rather the question of what to do with it, and not identifying them. And when I heard that there should be certified ambulances carrying out such screening, I got rather scared, really. So I would rather concentrate on the existing screening, such as prostate screening, that will certainly be very much useful and rewarding. Thank you very much. And there is one more topic, dependencies, addictions, and Mr. Vobosil, so what's the situation in your expertise field, and what are the instruments that are the most effective? Addictions, this is a very complex terrain field. We carry out prevention and also evaluation of consequences of addictions. We evaluate risks of addictions. Probably every single person has a potential of different addictions for reasons I'm not bound to explain. And this is the initial statement. When you look at prevention field, primary prevention was already mentioned. Within schooling system environment or context, we can see that systemic primary prevention is very little effective, almost ineffective. What helps is rather highly specific prevention. We call it indicated and selective prevention. In other words, we focus on risk groups, risk individuals, because in terms of those, prevention works. And this covers early detection and other things. While if you speak about primary prevention, even if it's indicated and selective form, is rather little effective until now. If you take schizophrenia, when being in the context of mental diseases, diseases. Schizophrenia, usually it gets demonstrated only with the first sign demonstrated. If you make preliminary prevention, it just doesn't work. And the same applies to addiction. So when it first gets demonstrated, you may sort of intervene to prevent it, I don't know, by the fact that you would support family context and such things. It would be very difficult. While if there are first demonstrations already, you can target your prevention. What about smoking? Smoking is the biggest killer in terms of preventable death causes and connection with social effects. We know that for alcohol and illegal drugs or digital addictions, social effects are very high, which is not the case of tobacco products. What works in general way is substitution, whether it's substitution treatment or substitution, for instance, in terms of smoking, when you spoke about case studies, substitution in the way of vaping. I mean, market brought it. People exert a pressure on tobacco companies. We pressured the tobacco companies so that eventually they brought something that was effective. Before, in the past, they were rather pharmaceutical companies that brought some remedies, but they didn't base them on behaviors of consumers, and therefore people didn't accept it so much, while tobacco companies came with a substitution that was so attractive for people that they accepted it. The things that were so long regulated also went to the fact that people got highly educated. So combination with market attractivity and high regulation, not prohibition. This is what I want to stress out.
So this was not successful. There is a number of substances which have been prohibited since 1961, and they keep going up in terms of figures. But if you look at the curves, after the war, there was a huge increase, and then it stopped and started going down again when there was strict regulation. And then all of a sudden there is substitute substances. Look at Sweden. It's a hockey country, and all hockey players chew on snus, and yet the number of smokers went down to 5%. So there is a huge decrease in pulmonary diseases and especially heart diseases, and especially premature death. And here comes in the question of regulation. And in the Czech governmental agenda, there's a statement which says that we'll regulate substances based on the risks involved, so that there would be less risky substitutes on the market, no matter what era we are talking about. And this is work for many dozens of years, because we need to educate not only politicians and people, but also professionals, because there is a huge debate, for example, about whether in tobacco or alcohol products there is any harm reduction approach available. Okay, thank you very much. Now, let me touch on the benefits or impacts in addictive behavior based on the principles you've touched on, and which are part of the governmental agenda and action plan and many other documents adopted by the government, which we should adhere to. So what would be the impact on the public health and economy if it works. We have a very unique action plan, or global action plans. I've traveled all over the world to tell people about our government's action plan and the national strategy. But, I mean, the implementation is kind of lagging behind, whether in terms of funding or legislation. Of course, we have made calculations, and there is a number of studies telling you how much the state will save in health and social insurance, and even the correlation in terms of collected taxes. So we know that one invested Czech crown invested in prevention will save, will amount to a saving of 3 Czech crowns. So, looking at the impacts in the Czech Republic, we are calculating with about 60 or even 80 or even 100 billion Czech crowns in terms of the cost of everything related to addictions, whether it's smoking or other substances. So, if we know that we are able to save dozens of billions if the system is set up well. And this concerns not only smoking, but also other areas. In terms of smoking, everybody understands that people who die early due to addictions die in active age. So last week I was in New York, and I talked to the economist who came up with the figure. We know it all from, Prime Minister. He said, it's not true that we'll collect less in taxes from smoking than what we spend, because these people will die earlier and will make savings in pensions. So I was talking to this gentleman, and he came up with this figure, and eventually he said, well, the argument was not as good as I thought. But looking at the deaths of people dying of addictions, these are usually people who also drink, smoke, and have less physical activity. Thank you very much. Now, without moving on to your personal recommendations round, it's not about the recommendation of your society, but your personal recommendation. I'd like to know, you are specialists in different fields. Have you learned anything new from this debate? Would anybody like to start? Well, or is there any questions you'd like to ask? Well, I'd be interested in the work of GPs, because for years we've been saying it would be necessary to get some information to people through GPs, because that's the best network. Most of the population goes to see a GP. And in terms of addictions, it would be the fastest way of communicating with the public. And you were kind of skeptical, so my heart really sank. Doctor, what would you say? Oh, well, I'm a life optimist, so I wouldn't want to spread skepticism. But the tasks of GPs are many, and there are many patients coming in, and the time is limited. But the GP has one advantage compared to the others. The GP gets to see the patient repeatedly, although for a short time, but several times a year. So he or she has a chance to talk to the patient. So maybe if you relieved us in other areas, such as, writing various types of assessments and retyping various types of documents about disabilities and stuff like that, which accounts for maybe 30 or 40% of our time, we'd be more than happy to devote time to this activity, and I'd love to delegate the other activities to people who could do that very easily without having the specialization. Professor Fall, you are our foreign guest here. As you were listening to the words about prevention from the different colleagues from different fields, what was attractive for you? What was maybe Czech specific, and what's different in Poland?
Thank you for this question. I was actually, just going to cut into the discussion because, what we sometimes forget is that the costs of the diseases caused by any addiction, especially cigarettes and overdosing alcohol, it's not only direct cost. Everybody's aware of direct cost. Oh, you get sick, you need to see a doctor. This costs. You go to the hospital, this costs. You need to get some drugs. Yes, there's a cost. Sometimes we forget that these indirect costs are at the same level or in several diseases even higher than the direct cost. The indirect cost is simply not going to work or something that we call absenteeism. But we have also presenteeism. So a person going to work but not feeling good, so not doing the job well, which ends up, that, his productivity is false. People tend to go to retire earlier, so they stop producing. And the argument that you gave, that an economist saying we save because they die off earlier, so we save on the pensions, was a little bit below the discussion level. But I know that there are several people who say so. So coming back. Poland is not that different from the Czech Republic, and Czech Republic is not that different from Poland. We have more or less the same problems. We have more or less the same, communist background and 70 years behind. So our healthcare systems were very similarly working for a long time. Now, the differences appeared, but still, most of us, or maybe not most of us, of course, with the exception of the ladies. But most of us were born during the communist times still. So the first injection, the first flu injection, I got in the communist Poland. So the background, really, we have very similar. So the problems right now in public health and in health in general, we also do have very similar. And when you're saying that there is a huge discussion about the implementation of harm reduction, can we or should we or shouldn't we? Well, I know that discussion is not only in our part of Europe, but I think at least, as I said, in Europe or in this part of Europe, would it be nice to have one strategy. We either go that way or we say no, we have proofs otherwise. Which I don't believe, because I'm a pragmatist. I'm not a purist saying that, either you quit smoking or I'm not interested talking to you. No, I'm the pragmatist. We need to talk to the patients who smoke, because even those who are cancer sick or even those who are heart sick, some of them still keep smoking, and we need to help them. And this is something that maybe during this conference, the fourth international conference, we can just start discussing a local European strategy. If the other countries will not join, they will not join. But maybe finally we look at the background that we, as I already mentioned, have so similar, at the problems today that we have so similar, and maybe we'll, push the ball together a little bit more forward. Because I don't remember in the history of mankind, of the Homo sapiens history, I don't remember any culture without smoking or drinking something. And I don't think that we'll create the first one. So we need to have substitutes, as already has been mentioned. And the substitutes help still some other. They help the fiscal policy, because the fiscal policy is very important for showing what is good or worse in the public health. But if you say only no or implement very high taxes without giving any alternatives, Then you have illegal stories, then you have illegal import, illegal production. But if you have a right fiscal policy, right education, and then for those who still cannot comply, you have substitutes, well, maybe this is the way we should go together. Thank you.
Děkuji pěkně.
Thank you very much. Associate Professor would like to add something, but let me say that thanks to Professor Fall, we can move on to the recommendations. I think this was a really wise statement. The situation starts to suggest that maybe we'd like to prevent people from choosing whether they'll use e-cigarettes or heated tobacco. Well, there is no evidence whatsoever that these two products should differ. And I think that the regulation shouldn't differ either. It should, in my opinion, be as low as possible, because there is a big group of people who won't be able or willing to give up their habit. So if you manage to switch them over to these products, it's definitely a better option. I'm not saying more healthy, but better. Okay, going back to Professor Hanslik, my question is, what recommendations or measures would you welcome? Just whatever you want to say. I'm talking about the area of prevention and the regulation or measures that should be taken either by the ministry or the whole government or health insurance companies, anybody you like. Thank you very much. That's a beautiful game. I definitely assign work to everyone, because all of us here have been talking about increasing the literacy of the population.
If we do not do anything, we would die earlier. Smoking is dangerous, of course. Addictive substances are harmful, and so on. So everything was said here. And the Czech population is certainly lagging behind. This is the first step. The second step, patients who want to do something with their health condition, they should be given conditions. They should be positively motivated. We should find means how to implement it. I know that sugar tax is now being discussed, and I know that this is not the right context to discuss it here. But I can imagine we could search for means that are not yet available in the health system but should be given back to the system. So this is also one thing. And last but not least, we should create conditions for physicians, for GPs. I do not want to make Dr. Shonka scared enough that we would task him with more jobs. No. But if we transfer administration work somewhere else, they should be given freer hands to work with other things. And as Professor Neuschel spoke about, nutritional therapists should be involved in other professions in order to be able for us to treat effectively obesity. And for those who need drugs, we should know for sure what are the patients, the obese people, what drugs should be given, how they should be reimbursed, and for how long time, and in what doses. Dr. Holly, thank you. Dr. Haluzik, and now Dr. Holly. How to say it shortly? In my view, in prevention of mental diseases, probably in all mental diseases, but with a specific focus to children and adolescents, not forgetting parents, I would underline a preventive potential relating to parents, in terms they should be educated how to speak with their children about mental diseases, how to increase awareness. We also need a certain network once we are able to identify that there is a problem of mental health, we need a network of low threshold treatment facilities, so that it doesn't take half a year, 3/4 of a year to come to an expert. We need peer programs, we need educational programs. From evidence, we can see that preventive facilities must meet some community principles, some multidiscipline criteria, must work with anonymous consultation principle, which is rather difficult in our context. And the one before the last point, I would say that the way we divide disciplines into children's and adults' disciplines, this division doesn't work always. So the scope should be between the age of 12 and 20. This is exactly the transition period when it is difficult for a young person. So applying multidisciplinary approach to this time interval, involving both aspects and underlining already mentioned peer workers, their involvement, those people who have their personal experience with mental disorder and therefore can speak from their own basis about it, and their experience is so valuable because somehow it makes much easier for children and adolescents to get interested in how to improve their mental health. This is the way how to increase their personal motivation. You are such a kind person. It seems to me that you did bring some tasks to you yourselves and to doctors, but what about the health insurance companies? From central authorities' point of view, for our domain, I think leadership is very important. An entity that would take a position of a leader and moderate the debate. I think that over the recent years, it turned out that we would not be able to tackle the issue just as health professionals. The fact that there is now this National Council for Mental Health, this is one of the new initiatives. Just 20 minutes ago, a debate on these activities between the National Council for Mental Health began at the Ministry of Health. So it's one step forward, but finally it's always money, money, money. Dr. Neuzil, head of the department, I do it not in the order of the program. What would you say? I would say that I cannot expect anything from the state. This is my personal credo, and as the minister said, the Czech cardiovascular society came with the national plan. Cardiological Association came with a cardiovascular plan, which is to be approved by the government and parliament, and then the Czech society, and whatever political team will govern. I think that some basic values remain, that new political teams do not create new and new values, because it's not important that every time new plans are set up, you have to set up a doctrine that will be apolitical, and that will be not dependent on specific political teams, whether they are politicians from the right or left or any populist party. I think to bring Czech population, community towards a certain individual responsibility for their health is what matters. As Professor Haluzik said, if a person treats his or her diagnosis responsibly, should benefit from positive points. If irresponsibly, should be assigned negative points. And if there is a person after the second or third myocard infections and still smokes, should not be covered by the health insurance as somebody who doesn't smoke. As Mr. Votruba said, I know that current alternatives are not ideal, but we must bring people to their own responsibility in such a way that the system is both attractive and repressive, and it always goes through money, money, money. So let's create a plan that will make a change, that the society becomes responsible. The same applies to vaccination. I will not get upset or heated here. This is, again, the question of one's responsibility. Or, as Petr Šonka said, we must be positive and treat it positively. Nožil.cz doesn't exist yet.
Just said that own responsibility for my own health should be introduced into the system. There is one problem, at least in Poland, in the constitution of the country. We have written that unlimited access, unrestricted to all health care publicly funded. Yeah, so we need to start with the constitution.
Jasně. Pane docente, vemte si mikrofon a můžete se obrátit.
Associate Professor, yes, take a microphone. Yes, I agree. Constitution must be changed. Absolutely. I agree. Absolutely. We should not have all the same access to health care system. If we are irresponsible in our own attitude towards the healthcare system, it should be reflected. We should stop lying to ourselves that unrestricted, unlimited access is guaranteed to everyone. In terms of the very simple question you raise, what I would wish that practically everything changes. People are more responsible, move more, smoke less, they are not obese, that the government and society support them in this. Nothing of that happens. People get support through NGOs, which is not systematic and therefore not good. NGOs should be at the end in an advanced society. I do not agree with you in this point at all. Anyhow, the system must be or should be set up in such a way that NGOs are a helpful entity, not a leading entity. It doesn't decrease the importance of NGOs. Responsibility of a person is the essential point. And it cannot be tolerated that some populist teams of politicians create the fact that what you've been taken off, you will be given in return. Well, that gets very specific.
Czech Republic that we have in Poland with some guys, going and telling things. But, by the end of the day, we're all proud that we're living in democratic societies now. And a part of democratic society is a civic society. And being a member of a civic society means not only that I have rights, but I do have obligations. And one of my obligations is to maintain my health to serve the society. Once we will understand that, the problem will disappear. But the guys who are running around and taking dumpsters, they simply make that not all of us still understood what a civic society is.
Děkuju. Chtěl jste ještě, pane docente, dokončit?
Nic, já jsem chtěl jenom dodat, že by bylo ještě taky na druhé straně skvělé, kdyby lékaři měli dobrý přístup k technologii a k řádné edukaci, to by bylo taky fajn a to se taky neděje.
Dobře, děkuji. Obracím se na pana doktora Dražana. Jestli
Jsem tu.
Jste tady? Dobře, tak ještě poprosím obrázek. A my jsme si slíbili, že jak si byste mohl zmínit třeba, jaké změny byste doporučili, abych teďka asi nechtěl hovořit, které očkování ano, které ne, ale jestli je tam nějaký prostě systémový aspekt.
Changes would you recommend, whether there is any system, the voice in favor of vaccination is not heard enough. It shouldn't be just separate exclamation of yours or somebody else. Is there a system that doesn't work as such yet? I think that in terms of vaccination, personal responsibility cannot work in a same manner or similar manner as you spoke about it right now. It's difficult to recommend to a parent that the child should be vaccinated against rotary infection and that it's paid for. I think that there are fields where politically it is unacceptable and not possible, where personal responsibility, for instance, of parents for vaccination of parents should be treated like. I think that both direct means and indirect means should be invested into it through education, for instance. We should also analyze what is the return of all the money invested, and we also have to think about our legislation. If introducing a new vaccination reimbursed by public health insurance necessitates a change in law, we will continue lagging behind every year in line. So even if we discuss that every year like we do, we lag behind, and so it's the question of money and the level of information, of awareness. Dr. Shanka, I will be rather realistic. Of course, I sign everything that's been said, but I would get back to what I said already. I would be happy if the state, I do not expect anything from the state, I expect it not to complicate my life, which is not always the case.
So I would appreciate if the Ministry of Health would actually issue our draft of the bill on prevention, which is in line with the National Cardiovascular Plan, because the regulation deals with early detection of chronic disease of kidneys, chronic heart failure, early detection of diabetes, and things like that. And today there is a huge gap in detection between the age of 18 and 30, because there is now laboratory testing, which would be part of the preventive checkup. And I think that early detection is totally primordial, so that these patients wouldn't get to the late stages where another intervention is needed. Also, I'd like the state to lift the prescription possibilities, because our possibilities are limited, especially in terms of diabetes and heart failure, and also dyslipidemia. And the result of the preventive checkup should lead to a change in the view of the patient at risk. I think it's no use looking at a patient as a patient suffering from diabetes. we should take a comprehensive renal cardiovascular approach, whatever you want to call it. And the outcome of the preventive checkup should be scaling the risk of the patient. And then hopefully there should be another step, because when the risk will be defined this way, we'll be able to work with this patient as part of the disease management of chronic disease. Thank you very much. Thank you, Chair. And the last but not least is Magister, who is going to who is currently a professional advisor to the Prime Minister. Yes, I can only give advice which I really believe in. So let me start with actually cancelling the Ministry of Health. And I'm totally serious about that. I mean, what's going on in some countries? Some countries have ministries of social affairs and health combined. And this is a follow-up to what my colleague said about mental health. Some of the care lies on health professionals, but it shouldn't be the case. They should be relieved from some duties, because some of the work is at the border between social and health care. And I think this is really missing. You were talking about low threshold centers for people with mental health, and we know that regarding people with addictions. This is how it works when people cooperate, but we know that there is a wall between these two ministries, and they are unable to put together a law, although it concerns these two fields. The people simply don't communicate, and the approach to the care is really, it's as if they were throwing grenades over this wall between these two ministries. And whenever I talk to either one of them, they'll say, oh, this is not my fault, it's the other ministry's fault. And I think this is really important. We need to actually change this way things are done. And I actually think the only way to deal with it is simply joining the two ministries, although this is not on the agenda of anyone. Also, regarding prevention and maybe primary prevention, the money we invest is only 3%. 3% of what? 3% of all the funds spent in the Czech Republic on prevention in terms of addictions. There is an amount of money for the treatment of whatever, but only 3% goes to primary prevention. And of course, secondary and tertiary prevention is also important, as it was said by our colleague from Poland. Next, rational evidence-based regulation. Rational evidence-based regulation which would lead to the availability of such products that will bear less risk. And this has to do with the tax system and all the different kinds of regulation that can be made by the state. We know that it works. We know what we should do. It's not that we are in a fog. We know very well what we should do and what works. Thank you very much. As we said, there is the governmental agenda.
On a very short question, because we've been also discussing combining these two ministries in Poland several years ago, and still we were even trying to add the Ministry of Work, whatever it's being called, to this trio. The only thing that we were afraid of is that the health has always unmet needs, so needs a lot of money, and that the health part of such a created ministry will drain all the money from the entire resort, leaving nothing for social care and work.
Jestli můžu jenom jednou větou, tak...
Well, if I may, the ministry with the greatest budget is the Ministry of Social Care. Well, I think it's the best time to end before we eliminate some other ministries. Let me thank all those who got involved in this discussion. Dr. Drashan, who was online, thank you. It was really interesting to hear the opinions of this wide variety of experts. Thank you very much. And for all the rest of you, the conference will go on. There will be a break and we'll be back at 2:30. Thank you.
Ladies and gentlemen, dear Minister, dear Vice Speaker, Deputy Speaker of the Chamber of Deputies, allow me to welcome you together with all participants and ladies and gentlemen to the third panel, which is dedicated to the population health and health risks and also competitiveness of the European economy, European Union as a whole. Allow me to welcome esteemed guests among us, Mr. Richard Rashi, Minister for Investment, Digitalization and Regional Development of the Slovak Republic, Mr. Karel Havlíček, Deputy Speaker of the Chamber of Deputies and Shadow Prime Minister of the Czech Republic, Mr. Andrew Bounds, who is Brussels correspondent of the Financial Times, Mr. Zdeněk Kabátek, Director of the General Health Insurance Company of the Czech Republic, Mr. Matej Fekete, Vice Chairman of the Board of the General Health Insurance Company of the Slovak Republic, Mr. Francesco Moscone, economist and important representative of Public Health Department at Brunel University in London, as well as Ca' Foscari University in Venice. And last but not least, Mr. Aleš Rod, who is member of the National Economic Council of the Government of the Czech Republic. Ladies and gentlemen, speaking about competitiveness of Europe is a topic that's been discussed from many different aspects. There are such aspects as innovations, regulation, tax rate in different member states, but what is sometimes forgotten, perhaps, is the aspect of health of population. I would ask Mr. Rashi, do you think that for the European Union economy, competitiveness, health of member states' population is important? Thank you for the question, and let me wish you good afternoon with a very short reply. Yes, I do. Let me welcome this opportunity to be the very first speaker in this panel. Thank you very much for the invitation. I think that these international conferences organized since 3 editions, this is the 4th edition. I've been invited to all of them, and I appreciate them very much. I am a physician, although I do not practice. This is a profession, a topic that is very important for competitiveness of every country, and I would say that the European Union still has troubles with how much means should be invested from national member states' budgets into health services so that it brings tangible results. I've been an economist at the same time. I've been a Minister of Health at a certain time in the Slovak Republic. And investment into health is something you make today, and it will bring results at the time you are not a minister anymore. So what's being a current need, what has to be invested now, will bring undoubtable effects later on, and therefore possibly it's so difficult to find money for the investment. And the results being brought by the investment very often comes after 2-3 political cycles. I am fully aware of the fact that any such investment we will commit ourselves to now will bring benefit or positive points to other governments, to other political representations, but still we should take it as a certain political inheritance we left for our succeeding generations, because health of the population is important and it's closely connected with competitiveness of our economy and European economy. Natality rate is alarming in our country and throughout Europe, so even more so we should concentrate on population health. The same question to you, Shadow Prime Minister Havlicek. Thank you for the question, and thank you also for the invitation for having organized this conference. Let me use a couple of figures for my reply. A healthy population undoubtedly is a good beginning for not only budget but also for gross domestic product. From the point of view of budget, it's clear, because we are now speaking about retirement system. Pragmatically said, in a couple of years there will be the senior citizenship health as a major problem, and we will face serious problems in a couple of years. And if you add to it all other problems concerning GDP, the growth of it in the 20th century, we will take it as a whole, the increase was due to a healthier population. And it's known that a crown invested into healthcare is being multiplied by 7 in terms of benefits, of results. And therefore we all understand clearly that unless we invest into prevention, we will have to face much more serious costs to be invested in less healthy population. And we are at a conference where probably everybody knows that, but it is on politicians, on their awareness, on their level of information, and on their political responsibility. Because yes, you are right, results are known when they are not anymore in their political functions. Not long time ago, it was forbidden to us that Prime Minister is taken picture of in front of a cancer prevention program, and it was forbidden to put it into those in vicinity each of other. And now we should rather put it in direct vicinity, closeness, because it's exactly something that depends very much on decisions of politicians, how much is invested in prevention programs. It should not be forbidden anymore. We should rather order that pictures of specific politicians are linked to specific prevention programs against oncological cancers. Of course, you must have a politician that will not be obese, not be smoking. If you put the opposite figure on it, it would not be a good advertisement. Richard, besides the fact that you are an experienced politician, you were at the head of several ministries, you were several times a mayor lord of Košice, but you are also a physician. So at the beginning, give us your opinion on policies, which are the most important. I am traumatology surgeon, so I cannot recommend what, for instance, sport is safe for traumas of injuries. But if I take it from a larger context, I mean doctors of my generation or older, when I submitted the first anti-smoking draft bill, it was in 2009. The draft focused on ban on smoking in restaurants. Less than 50% of the restaurant space had to be smoking free, and then it was extended to 100% of restaurants smoking free. Nobody minds that anymore, but when we started with that, it was object of so many opposition reactions, and not only in terms of smoking, we were successful. I suppose that no one here in this audience would doubt a link between smoking and lung cancer risk. We are living in Europe, and bans usually do not solve much things or anything. Let me remind examples from Great Britain and other countries. And within our heads, our hearts, we probably should learn how to transfer from bans to risk minimization, I mean harm reduction. This is very important. Banning risky factors such as smoking and whatever should be applied on children, but not on adults. With adult people, you will not use bans in order to change their way of thinking and behaving. We must apply harm reduction approach, and this is what we apply, indeed, by also offering alternatives so that the most nocive alternatives are replaced by less nocive ones, and in order to reach the effect, we must really educate people to change their way of living, that themselves they understand that if they substitute more harmful things by less substantive one, they will get better. We have also a politician who has had experience from several industries. He's not a physician, he's rather an economist. So let me ask you, economic aspect of prevention policies, how much entrepreneurs, employers should take care of prevention?
Of course, prevention is the core and basis, even in areas where companies have paradoxically a negative contribution. We all agree that in primary prevention we should fight against the use of tobacco, alcohol, addictive substances, and so on. But paradoxically, the producers of tobacco and alcohol are very rich, and if you communicate well with these producers and they manage to somehow decrease the share of tobacco products or maybe change them into healthier products, it is a way forward, good practice. Of course, then there is the involvement of SMEs who want to have healthy employees, and they are involved in prevention because they feel that this may help increase productivity. And the state can allow the companies, for example, a tax deduction if they support their employees this way. I'll give you an example from a different sector. Some of you may know that I've also been in charge of science and innovation, and we've introduced a system which I thought was very efficient. Tax deductions for resources which we put into innovation. So actually there was a double deduction. If the company invested in innovations and prevention, they got a tax deduction. So that works really well, and you could do that also, for example, if a company invested in its staff's health or prevention. So I think this is really good. And one last thing I'd like to say in terms of broad prevention, that's support and promotion of sports. We are talking about the money invested in sports and what we should do on the part of state. And everybody talks about champions and the number of medals we bring home from the Olympics. But obviously, there is a number of school clubs and sports clubs which do not have any champions, but they promote the kids' health, and economically it'll get back to us. So money invested in these clubs, not the Olympics, are going to bring back benefits, because the more we invest, the lower the necessary money will be. You were talking about research and development. We are close to parliamentary elections. Do you think that your party will want to incorporate this concept in its election agenda? Yes, definitely. In fall, we'd like to come up with these incentives as part of our agenda. And let's be objective, this government nor the future government will have an immense amount, indefinite amount of money, but we can provide indirect investments, and this helps to support companies and businesses. Thank you very much. Now I'd like to move from the Czech Republic over to the pan-European level. Several weeks ago, Mario Draghi published his report on competitiveness of Europe. Andy, I'd like to ask you, what do you think about the health sector and health risks as a part of a strategy for competitiveness of the EU? And is this reflected in Draghi's report?
Hi, thanks Ivo, and very delighted to be here back in Prague. I looked at the Draghi report again last night. I counted 10 references to health, which isn't that many in a 400-page document. 2 of them were talking about how good the European health system was compared to our competitors in the US and China, but also that the necessity for an improved economy to keep the health system funded. And then the rest of it was really about innovation, fair enough, so for example, he was talking about clustering in certain hubs in Europe rather than sort of trying to have innovation hubs in every country. You'd have half a dozen maybe across the bloc, so you'd really concentrate, which will be politically difficult, I would imagine, because Prague has a great health cluster, and I'm sure we'd love to have a health, but then you'll have Paris saying the same, and you'll have, Stockholm saying the same, Denmark, Copenhagen. But also he talked about the way we're falling behind in healthcare, research and development, especially compared with the US, and new drugs. And partly it was down to heavy-handed regulation. We tend to have a more cautious regulatory environment in Europe than the US, so it's, we have the precautionary principle. So he wanted some reforms. There's a very big pharmaceutical reform package coming through the EU, but it's been stuck, as usual, between the 27 member states who all want slightly different things. But if you look at the evidence, we are falling behind in drug discovery compared to the US and China, and we're falling behind in R&D spending. I think we spend something like half as much public money as the US and a quarter as much private money as the US. And when you think the EU is twice the size of the US, that's not great. But what he didn't really assess was what we're talking about, really, which is about, a healthy workforce, which strikes me as he missed a trick. Because, we have an aging population, we have mounting costs to keep people fit, and people are damaging themselves through smoking or drinking, whatever it might be. And as our earlier speaker said, some investment in prevention actually pays off handsomely down the line in economics. So it surprised me that he'd sort of missed that out. I think OECD figures say that 0.8% of GDP in the EU is the cost of ill health, and people in their 50s tend to work less if they have a critical health condition, diabetes or cancer or whatever it might be. And some other statistics through the FT produced only last week, actually. We have a guy who does a lot of data, and he was looking at young people's health. And he was showing that in the UK, and this is true across Europe, but especially in the UK, the amount of young people saying they're not fit enough to perform, as they would like in everyday life, has grown hugely since the financial crisis, 2008. Partly it's mental health issues, partly it's post-COVID issues. So that's gone up from 7% of people aged 16 to 24 to 20% of people aged 16 to 24 in the UK, saying they struggle to do some everyday tasks, which is 1 in 5. And if you think, well, if they're doing that at that age, what are they going to be like in their 30s, 40s, 50s, 60s, when we're already short of a workforce? So I do think, it's worth a bit more focus as this conference is trying to do, and whether the next Commission will take this forward. They've done quite a lot in health, as you know, because we had the pandemic, so they started joint vaccine purchasing and all the rest of it. But a lot of these powers aren't really European powers. They tend to expand into them. But they're more crisis powers rather than preventive powers. They haven't done an awful lot on prevention. So it'll be interesting to see if there is a request for that. And they can only really do it with the Member States' support. One thing that a senior health person did point out to me yesterday was, if you looked at the COVID vaccines in the first place, a lot of countries tried to buy their own COVID vaccines, then everybody started to say, we'll do it on an EU level. When it came to the Mpox, 2022, when it first broke out, Member States were ringing up the Commission and saying, can you buy us some Mpox jointly, please? And that, this person was saying that would have been unheard of pre-COVID. So there's a lot of expectations now out of Brussels on health policy, but it sort of requires buy-in from national governments as well, who hold most of the levers. Thanks.
Co konkrétního si myslíš, že si...
So what exactly do you think will the European Commission take from the recommendations?
Konkrétního si myslíš, že...
Okay, so what do you think they'll have from the European from the recommendations? What can we actually expect from the Commission?
Well, if you look at the mission letter, which the Health Commissioner receives, again, it's more talk about emergency preparedness. There's not an awful lot about prevention, I think, again, it's very much dependent on how much latitude the Member States want to give. They've got a cancer plan, which has been quite successful, which again is built on a voluntary basis by Member States. So, the Commission sets targets for improved cancer care, and the Member States try and meet them. But they can't dictate what should happen. But that's been quite successful. They've also got this European health data space, which is a sharing of medical data, which I think, again, could go further, but depends on buy-in from Member States. And the idea then is the more data you have on people, the more useful it is for researchers. But then you get into the whole data protection issues in Europe. So again, I don't have a crystal ball with me, I'm afraid. But, you could see where things might go. There's a project of sequencing the genome, so there's 1 million genomes in the EU been sequenced on a voluntary basis. But I just think, and also I think this pharmaceutical reform really needs to happen. There's also this question of the medical device, regime, which can you regulate certain medicines slightly on a lighter touch basis, which again, in the EU, you're often dealing with the one, the lowest common denominator almost, so it's like, well, maybe 2/3 of the Member States want to go ahead with something, but the others don't, and therefore it gets held back, even if, in theory, you could push it through on a majority voting basis. People like to do things by consensus. So it does mean everything moves very slowly. And, the new Health Commissioner, of course, if he succeeds, will be Oliver Várhelyi, who's, an experienced commissioner, but he's Hungarian, which may hold against him a little bit in Brussels. He's not going to have perhaps the political backing that previous health commissioners have had, who've come from centrist parties. So I think he might find it a bit more difficult to sort of force his stuff onto the agenda than maybe other commissioners. So we'll see.
Thank you very much. We've heard about two major institutions, the European Commissions, the Member States, but then there is also another institution, and that's the European Parliament. And I'd like to welcome here online an MEP, Ondřej Krutílek. And I'd like to ask him about his perspective. What do you think can be expected from the European Parliament? Thank you very much, and I'm happy to be here with you. I hope you can hear me, see me. I've been thinking about it, and I was also listening to the last speech, especially Andy's words, and I'd like to start by saying very basic information. Healthcare is a shared competence between the member states and the EU, and that's the very basis. So despite the COVID pandemic and a number of other things, the European Parliament and the EU is actually at the short side of the rope, so to say. I'm convinced that if we integrated healthcare more on the EU level, it might not have the best results, because the different systems in the different member states are quite different, especially in terms of payments and reimbursements, and this might be tricky. So the role of the EU and EP consists mainly in allowing or facilitating some services or some things that could be beneficial for the whole bloc. So we can actually promote their spreading across Europe. Quite specifically, over the last 5 years, the EP has been dealing with the pharmaceutical package and also the European data space proposal. And here I'm talking about anonymized data among individual member states.
This, in my view, is certainly worth being paid attention to, too, because it can also help prevention, among other things, and it can increase, if we speak about it in general terms, it can increase the level of the European Union health state in a whole. There were many outcomes of it. Mario Draghi brings also in his reports many outcomes, but I'm not sure whether solutions he indicated are the very right ones, because the main problem consists in money. Mario Draghi submits proposals that will cost something. And I think that if we want to have a better health care within the EU, I repeat again, we should rather honor the coordination right or competence of the EU in businesses and in competence crossing the national borders, but I would certainly not unify individual member states' systems. And it was already said, there will be auditions of individual commissionaries for particular sectors. I do believe that the one who is proposed for the for the sector of health, and the one for energy and industry, I do think that these should be considered together, and once the new composition of the E-Commission will be finished, the new E-Key can play important role in taking their own initiatives or in supporting like-minded deputies' actions who are interested in health, mental health, or prevention programs, or cancer struggle. So this is, in my view, the maximum what can be done from the EP. And one more thing, there is a multi-year new funding framework in connection with Refinance Europe. And in this respect, both European Commission and Parliament can play an important role in supporting science and research, because these can advance us trying to balance, at least partially, the position our position that is not optimal when we look at other big entities throughout the world. I don't say that Refinance Europe is the best possible program, although Mario Draghi would probably wish that the budget for science and research multi-year financing program budget gets doubled, but at least it could be shaped by the European Parliament into such a form that it would benefit and help the European level health situation or healthcare system situation. Mr. Ashlow, how do you perceive, Mr. Rashi, how do you consider the level of health care in the EU and Draghi report? Is it one of many or is it a pioneering report? We do believe that it will not be another report for report, that it will be something that will become a factual document for the member states. And in this unprecedented period we lived under COVID, it was really unprecedented period. It changed perception of everything. There were many things done and many mistakes committed, which is a typical phenomenon for a critical period of time. But a good lesson to learn from that period was that when we set up healthcare systems, that they should contain not only prevention and treatment as typically conceived, but also in the spirit that medicine should be evidence-based medicine, and evidence proving correctness of our tools and procedures should be in place, should be verified, and politics of the EU, not only in terms of healthcare, should be, again, evidence-based, done. Medicine is often done not based on evidence, but often based on our convictions. And when we think about competitiveness of the EU, sometimes measures or challenges are adopted that in their outcomes create conditions rather for decrease of competitiveness, not its increase. So I hope that evidence-based approach will be adopted and implemented throughout all sectors, not only healthcare. Mr. Havlicek, what's your opinion on how the member states should use Draghi's report? I'm rather skeptical. I don't think it will be an inspiration for the EU member states. I think it's a frustrating report. It's just an appalling report in terms of the message. It's very saddening. And I would say that not only a critical approach was applied, but even a friendly, accommodating approach, and still the results are very sinister, very depressive in terms of what we can expect, what we can count with, and nobody takes it seriously enough. And still, we should based our dealings on it. Political cycles last 4 years, and instead of admitting something is not okay, let's not look for culprits anymore, it's not important, let's look for solutions of problems I face. This is what should be done now. But I still think that the European Commission and other bodies will continue working in their policies, and therefore there will be rather cosmetic changes, not the basic changes. Of course, different countries have different self-reflection level. Their governments change, so sometimes they are better able to admit their mistakes, sometimes less able, and this purification process is still so important and not always applied. What is in the under context of the Draghi's report? Let's not look at what is the gap in public finance. Of course, it's important, but let's not look at it in terms of figures. Let's look at it from the economic point of view, but a larger extent one. Whoever worked in a European institution knows that it's not possible to judge one's dealing or dealing of any institution or entity for just 10-15 years. What I think our priorities in a healthcare system is alcohol consumption, tobacco consumption, substances, addictable substances, and obesity. And these 4 priorities are linked to our willingness and readiness to invest into sports, and not only in top-level sports activities, but to mass sports activities. I mean that we will increase more money into mass sports. Today we invest 7 billion crowns despite 30% inflation rate. So we suppress, let us say, that there will not be so much alcohol drinking or mass drinking or not so much smoking and so on and so forth, but still there will not be more sports activities. So investments into mass sports are very meaningful. Let's get back to health insurance agencies that are not only guarantors of health care, but also certain defenders of investments being done reasonable. Mr. Kabatek, director of the General Health Insurance Company, can these companies afford thinking about things not only in terms of figures, but more largely? Good afternoon. Thank you very much for the invitation to this debate. I have listened very much to my predecessors, and I would like to go back a step from the European loan to the Czech little grass field and to weaknesses of our healthcare system. Relating to what Mr. Havlicek said, unless we launch some radical changes, and I'm not avoiding your question, unless we don't do that, we may face very serious problems, economic problems very soon. Over the last 10 years, roughly described, we were living on a little cloud which was not destroyed by COVID crisis. I recently spoke with our Slovak colleagues. Their perception was a bit different, but in our country, revenues of our system increased enormously, and therefore we thought we had no problems. We sort of lived in a golden dream, and our healthcare system provided high-quality services, highly accessible. There is not much we should be ashamed of. But the problem is the situation will not last forever, and with that I get to the question of our host. Czech health insurance companies, not only they have to think economically, they must do that as well. We cannot just think in terms of 10-15 years, how much money we have, or what services we have to insure for our clients. In this respect, prevention is the basis. Besides the fact that we have some reserves in provision of services, we have to think about effectiveness of our services, and prevention is one of our tools. If we use prevention as a dominating predetermining factor for further development. And when I remember Mr. Havlicek's words before this conference, I gave an interview and I spoke exactly about this proportion. You invest 1 crown and it will get you a revenue 7 times higher, or results 7 times more rewarding. So when we try to be budgetary responsible today, we have also private investments into the system. It will not save us. We must look for reserves in terms of our costs. And in association with that, we have to eliminate cost increase in the future. And health insurance companies are obliged to think about these things. We want to discuss as soon as today how to increase reimbursement at those cross points where we cross both motivational patterns of behavior with our reimbursement. I mean, participation of patients in different screening, preventive programs. This is something that has increased by 25%, and that's a clear achievement, clear success. Without speaking too largely, I would say that health insurance companies not only have to think economically about that, but have to be safe-costing entities. Mr. Fekete, your answer to the same question, should health insurance companies behave economically, not in terms of accounting entities only?
Thank you very much. The company has prepared a paper on the different activities we provide, and you can find there also the calculations of costs and therapies. The General Health Insurance Company considers prevention one of the major topics, and we try to promote it all year long. And the result is about 200 events where we try to do that basic prevention, primary prevention, and we celebrate major success. The effort is also elsewhere. Not a long time ago, we still had what they called a dental benefit, which was quite liked by policyholders. If you went for a preventive checkup to a dentist, you obtained a discount on dental hygiene. This was really a good benefit, but unfortunately due to budget constraints we had to cancel it. But we are working on other benefits for the future. As the Minister of Health said this morning, prevention should be at the center of interest for everyone. We should really try to look after our health. And I'm kind of taken back by the fact that the moment we canceled the dental benefit, the number of patients coming for preventive checkups keeps falling. So if you come up with a benefit for patients to come for preventive checkups is really important. I'm really glad you talk about sport. We, as the General Health Insurance Company, try to closely cooperate with sports people, athletes, and we cooperate with them to promote sporting events. A memorandum with the Slovak Olympic Committee is a good example of that. We were present at various events organized by the committee, and we talked about prevention. There was a huge number of detected melanomas, and let me tell you, some people really underestimate these tests. Also, the train of health. That's a really good thing to do. We simply organized a train which went from Bratislava to Košice, and when people got on the train, we measured their blood pressure and things like that. We summarized the results, and it is alarming to what extent some patients, some people neglect healthcare and prevention. Just an example. There was a lady with a blood pressure at a rate of 210 to 110. They actually had to change batteries 3 times to make sure the measurement was taken correctly. And only after that, she actually realized she had a problem. So prevention is really important. We try to educate people as part of prevention. And we believe that thanks to these measures, we actually save money, which might need to be invested in the future. It's really hard to make an estimate of how much the savings are, but I do believe that this is a really important activity and will continue. You said it's hard to make an estimate of the potential future funding which would be necessary, but we are in a period of where we use data a lot. There might be a way to use these data to manage the effectiveness of costs in the healthcare system. So are you planning to involve AI, big data, digitizing in preventative measures? Well, we got a center for medical information, and with every change in the government, of course, the process slows down. Just like in the Czech Republic, there is a lack of continuity in some institutions. And now we are missing some data, but together with the Social Security authorities, we try to improve the situation. It's not just about saving costs in terms of the healthcare system. It's also about social security. Usually, when you leave on a sick leave, you stay sick for 46 days, and that's a lot in terms of the cost. So if we invest enough in prevention, the person won't cost money the social security system. Zdeněk Kabatek, do you think that for the future it'll be good to invest in data so that you, as an insurance company, can make better planning in terms of investments? Well, the answer here is quite simple. Yes, because this is really important. Only if you have correct data, you can make correct decisions. Each manager needs to have valid data to make good decisions. So obviously, as part of the activities which we do today, we try to kind of go into the new era, analyze the data, use AI, use the data of the Institute for Public Health, Professor Duszek, who talked this morning. And I can assure you that without correct data, there is no way to move forward or bring any effective improvements. Now, how about the economists in our panel, because they like working with data and figures, and their conclusions should always be supported by data. Professor Moscone, which preventive policies do you consider the most important, and what kind of databases do we have to assess prevention policies?
Thank you for the invitation. And I think the idea of using data, no matter what kind of data we're talking about, could be administrative data, microdata, macrodata, mesodata, non-conventional data, data coming from websites and so forth, is tremendously important in order to assess also the policy interventions of countries. So data, there's no doubt, with models and some theories, because remember that it is important to have a theory that you want to test with the data and not just take the data to speak for themselves. So my answer on the data, yes, we should use data, but if we want to evaluate certain policies, for example, that will be implemented in EU, hopefully as soon as possible, then we need to wait to gather more data to do our ex post evaluations. Of course, you can do also ex ex-ante evaluation. But I think the evidence bait for economists would be to use the data, see if the policy is effective, and then try to understand with certain methods whether the policy was the cause of the effects that are measured in terms of outcomes, could be health outcomes and so forth. So the data question is important for economists as well. Now, I would like to recall the Mario Draghi's report that you were mentioning earlier on, because I think we all need to read it and digest it. It's a lot of evidence-based kind of work, huge document. Now, the bottom line of the document is to basically say, I think, well, if the EU wants to maintain the competitiveness in terms of at the global and regional level, well, it has to do lots of changes, from innovation, as has been said, we said earlier on, to other, kind of radical reforms. Now, there is no doubt that the EU is lagging behind in terms of productivity and economic growth when compared to China and the US. And if you look at the divides within the EU, they're enormous, from the east to the west, from the north to the south, and these divides have a name. They're called inequalities, gender inequality, and this is what makes us different from the US, I think. And that's what Mr. Draghi wants to say. He doesn't want us to become Americans in many ways, but he wants us to revive productivity, boost economic growth, and look after inequalities. Although the picture is not rosy at all, because it has been said earlier on, we are an aging society, which is a good thing in the sense that life expectancy is increasing over time, everywhere in the world. If you look at life expectancy at birth, life expectancy at 65, it's a good thing, but the workforce is shirking, has been shirking. So there are less workers, and by default, that means that the output of the economy will go down. And if you look at Eastern Europe, some countries, if I may say so, are reluctant or, let's say, not inclined to welcome migrants, which poses other serious questions in terms of increasing the labor force in the labor market. Now, I think the fundamental question is, although fertility rate is at the lowest level, not just in Europe, in Canada. I don't want to talk about South Korea and say, oh, it's 0.5. Although we're living longer, and this in some sense is an issue for the workforce, the biggest issue is, are we living healthier? In other words, we should look at the healthy years of life more than life expectancy. And I think that if you want to answer to this question, you need to have a report like the British have done just recently, the Darcy report, where the British government has asked Lord Darcy to say something on the state of the art of the British population in terms of their health and the NHS. And Lord Darcy got back with a lot of evidence saying, basically, the NHS is broken, got to be fixed. The Prime Minister said, yes, it is broken, got to be fixed, but you know what? We're not going to pour more money to the NHS unless we do the reforms. We are talking about reforms that are not going to be done in 1 year times, We're talking about a decade. So I think in Europe, we should have a similar British approach in this sense. We should say, okay, are we living really longer and healthier? Well, a lot of indices are telling us that we have lots of issues in terms of healthy population. But can we improve the health of people, the quality of life of people? The answer, and this is the good news, I think, the answer is yes. We could improve the health of people so that the people can go back to work, start being more productive, increase economic growth, and then the governments will have more funds to finance also the reforms that they want to undertake. So Mr. Draghi does not talk about specific reforms, has a vision and a lot of evidence-based, but now we will be waiting for reforms. And this is timely because the European Commission right now is revisiting lots of directives. The directives are linked to tobacco consumption, to the taxation of alcohol, and so forth. So this is the time for Europe to have a vision and think about these reforms. And I think one way forward would be to basically reduce all these cases of cancers, cardiovascular diseases that are linked to our lifestyles, as we saw in this conference, and therefore we could actually reduce smoking. We could indeed reduce excessive drinking in the sense that these non-communicable diseases are preventable and manageable, and we could do that. But I think we should think about the principle in economics, which is the choice set, the consumer's choice set. I think that we should widen and enlarge the consumer choice set in the sense that people should have the freedom to choose between A and B as a product or a service if we want to live in a free country, okay? But people should have a larger choice set instead of having only high-risk products like consumption of traditional cigarettes, tobacco consumption in general. They should have other alternatives, as has been said in this panel, in the previous panel as well. Alternatives, innovative products like, for example, vaping. And I'm talking about vaping, it's a broad idea. If you think about vapes, you can think about e-cigarettes. I don't know if it has been said in this conference, but a lot of clinicians believe that e-cigarettes can be used as a measure, as a tool, as a therapeutic tool to quit smoking. But of course although I'm an economist, I don't like banning. I don't like banning goods and services because they never worked. I think that within e-cigarettes, there are products that we should ban. And these products are disposable e-cigarettes, which are bad for the environment and bad for the children. I mean, I was recently with a friend of mine, and I wanted to try the e-cigarette, the disposable e-cigarette. I'm not a smoker, but I was curious as a teenager. And I went to this shop, and I saw disposable e-cigarettes with lots of different colors, different flavors, from candy flavor and so forth. And I said, you know what? This is crystal clear. These disposable cigarettes are for the children, for our kids. There's a segment of the industry, and I don't think this is ethical at all, moral at all, that is trying to attract the youth, and we should stop doing this. On the other hand side, I think that it's important to enlarge the consumer choice set. For example, there are some products like heated tobacco that are not well advertised, I think, in our society. But if you look at the case study Japan, we can see that the percentage of smokers in Japan has been decreasing significantly, and in part, this is due because of the heated tobacco. If you look at a case study like Sweden, and we said it today in this conference, there is another product called snus that is banned in other countries, but not in Sweden. And in Sweden now, the percentage of smokers is almost 5%, which is a dream for a country like the UK that has a mandate from the royal family. Doesn't matter the political ideology to reduce the percentage of smokers to 5%. So I think that the answer would be a very pragmatic answer. Can we stop people smoking? Well, in an ideal world, I would like to see no one smoking or engaging in the high risk or, risk, products or behaviors in general. But this is an ideal world. So if we want to have a pragmatic view, we should enlarge the consumer choice set, therefore decrease different types of cancers, cardiovascular diseases, and therefore make sure that there is a reduction in hospitalization, a reduction in the treatments, so doctors and nurses will have more time to dedicate themselves to more pressing issues. And at the end of the day, this means saving lives. This means reducing the pain for the families of the patients, the pain of the patients, but as an economist, it's a good opportunity to save resources. Billions of euros, some of my research is showing, could be saved if part of the population, like 50% of the population, that is, let's say, smoking or engaging in other high-risk behaviors, would switched to other reduced-risk products. And with these saved resources, then it's going to be a political call. You can decide whether to reinvest them in the healthcare sector or any other reforms that you wish to do as a country.
Děkuji, pane profesore. Já bych se teď obrátil na Aleše Roda, který je dalším z ekonomů, dokonce je členem národní
speak about this thing further with a member of the National Economic Council of the government of the Czech Republic, Mr. Aleš Rod, who is an economist. What would be his recommendations for prevention policies that could be applicable, that are working, which ones should be emphasized and they work in Slovakia or in our country. Thank you very much for the floor. Thank you for the invitation. I'm very happy that I've been a member of this panel from the very beginning, and I would agree with everyone who spoke, because a competitive Europe is a healthy Europe. We all are aware of this curve that taxpayers who pay for the solidary systems, their share is getting smaller and smaller, while the population is not increasing so much. Also, there will be robotization, AI, there will be less economic entities being able to pay their taxes and increase the national revenue. So we will have to focus on increased productivity across all the economically active population and economic cycles. And we are not referring not only to postponing retirement age limit. It's just a part of the discussion. It will also involve what will be the share of people in their senior age in production of in the national economic contribution. So it depends on their health condition. And for me, prevention is a too large context. When I divide it into primary prevention, I mean preventing onset of an illness. When we try to stop any onset, I mean to identify early the diagnosis, or the secondary prevention when we try to slow down the progress of the illness, or the tertiary prevention. We must use different tools for these different stages and different cohorts. When harm reduction was mentioned here, when we look at the structure of costs while making diagnosis in the Czech Republic, we can see that more than 20% is in CV illnesses. We know that what are risk factors for cardiovascular diseases. We know when there is not yet an onset of the illness, what are the methods how to eliminate the risk factors. I mean, first of all, education. We can speak about obesity, healthy diet, alcohol and tobacco consumption, or we can eliminate those risk factors. Also, as somebody mentioned here, we can go from a certain consumption down to a zero consumption with a mix of different measures. We can also, for instance, reach sugar-less diet and motivate people to achieve different targets. When evidence-based approach was so much stressed out, yes, I agree, but experience of a different country cannot be always 100% transferred to a different country. However, they can serve as a certain example or model. I made a rough calculation from a well-known clinical data and trials, and in terms of absenteeism, 4% of working days in the EU are lost because of absenteeism. People are either ill or are at a medical checkup. And in the Czech Republic, it may represent some more than 300 billion crowns. When we multiply it by tax rate, 1/3, let us say, we can calculate what is the economic impact on the national economy. And these are several dozens of billions, or 1.5 up to 2% loss of data, evidence from Germany and Great Britain, or mental diseases, 4% loss in GDP, annual GDP. And we could continue sector by sector, and we would see that these dozens of billions we tend to say from time to time are not virtual amounts. They are clear, tangible amounts, and they cover different measures that can be assigned to primary, secondary, and tertiary prevention, involving diagnostics and treatment. And we should apply them really evidence-based measures based on that. And in terms of proper measures or policies, they should always aim to a clearly defined target measured by a evidence-based and clearly defined methodology. When we spoke about addictive behavior, for instance, if we want to reduce alcohol consumption or to reduce prevalence of tobacco usage in a given period of time, we must be able to measure that, to quantify it, and to adopt such measures that will have either deregulative effect or regulative effect. We must be able to work with the data so that every measure must be matched with a respective target and vice versa. And finally, two top-level politicians from the Czech Republic and the Slovak one. It was said several times that prevention is a multispectral thing. It involves education, awareness, taxation, sugar taxation, alcohol and tobacco taxation, nutrition as such. But there are also many other aspects and sectors that relate to politicians' work. Mr. Havlicek, into how many aspects of health risk prevention relate to politicians and necessitates a regulation and close coordination by top-level of politicians? I would say this is a topic that is extremely important for all of us politicians. And when we have spoken about prevention throughout the day, we somehow still tend to count rather with treatment. And if prevention is not done properly, though, it may cost us a lot and it may not be effective. This secondary prevention is related with the role of government. Let me give you a clear example. Nurse Petra from Masaryk's Oncology Institute, she's a wonderful woman. When I visited the institute, I made her acquaintance, and I was submitted to a whole set of these pre-oncology markers checkup, and when the results were communicated to me, I happened to hear that sometimes people have to wait for this half a year up to a whole year. And in this respect, I would like to say that people should demand these screenings, these preventive check-ups, that they require that it's done within one single day for them, or in a shorter notice. So regardless that how it is today, people should ask for a better arrangement. And of course, the government will keep saying for some time that money is not available for such an improvement, but sooner or later they will resign and invest in the improvement of the system. So let's not resign to all different economists or advisors who just look at the things from the accountancy point of view. Let's look at it from a largely economical point of view, and such investments are economically vital and needed. Richard Rashi, from your point of view, prevention, does it go beyond a portfolio of a Minister of Health? For sure, yes. And it was indicated already several times. Mr. Havlicek spoke about sports. Yes, we have a Ministry of Sports, and we deal both with massive sports and professional sports. From my point of view, we have to base ourselves, and politicians must start working, acting up on that, is that we do not see just one political cycle. From the health point of view, it's really something longer. We must rechange our way of thinking. If there is no ban applicable, we should use a harm reduction approach. And our political decisions should be adopted evidence-based, not feeling-based. If we succeed in this, then investment into improvements will not be wasting of money and will not be an unsurmountable obstacle for the minister or a politician. Thank you very much. It was a beautiful final word for this debate. Thank you very much, our esteemed speakers, and thank you very much, our dear audience, for your attention. Ladies and gentlemen, those who are still in the lobby or in the hall, please get back to this room so that we could continue. We may even close the door so that we can fully concentrate on our last panel of the 4th International Conference of the Healthcare Daily Economics of Health Prevention. We have this last panel, Prevention of Health Risks as a Shared Responsibility. We will treat the issue from different aspects, including the social one. Unfortunately, I have to apologize for the absence of Mr. Marian Jurečka, Deputy Prime Minister and Minister of Labour and Social Affairs of the Czech Republic, which due to some minor turbulences in the Czech government, he couldn't take part in our conference. However, I welcome among us a member of the Chamber of Deputies and Shadow Minister of Health of the Czech Republic, Mr. Kamal Farhan, who will soon be the Pilsen region governor. Very soon we can congratulate him. We also have Dr. Tomáš Salaj, member of the Health Committee of the National Council of the Slovak Republic. He has experience with the regional district healthcare services organization. We should have online Mrs. Kateřina Neumannová, Olympic champion and world champion in cross-country skiing. Forgive me for my virtual or remote participation only. I wasn't able to come in person. We also see Mr. Tomáš Zdechovský, member of the European Parliament. He is also online. And we will have a video delivered by one more European Parliament member. We welcome among us Mrs. Barbara Macková, Chief Hygienist and Director of the State Health Institute of the Czech Republic. We also welcome here Mr. Ivan Duškov, Deputy Director of the General Health Insurance Company of the Czech Republic. And last but not least, Mr. Viktor Mravčík, Advisor to the National Drug Coordinator of the Czech Republic, physician himself too. I'm not sure whether Mrs. Deputy Chairwoman of the... she's not here anymore, so we will not welcome her. At this moment, I would like to address both EP members and members of Health Committee, asking something we wanted to address Mr. Jurečka with, Minister of Labour and Social Affairs, because there are issues that may be of interest also for people in connection with Ministry of Health. Which points do you see in common between those two ministries? And we agreed that our foreign guests would be given priority. Mr. Tomáš Salaj. Thank you for the invitation and for the question. My colleague who will succeed me will certainly be in a better situation, because he will probably be able to say that in your country it goes better. In our country it doesn't work very well, cooperation between the ministries. This is a book, The World of Galaxies, The Problem of Somebody Else statement. If you say it's a problem of somebody else, you do not see the problem. And this is something that is rather typical for Slovakia. Perhaps it exists also in other countries, but in our country it's very typical. It's often said it's not our problem, it's a problem of somebody else, it's a problem of another committee, of another entity. And in my view, we are just amazingly talented to transform practically everything into a matter of somebody else's concern. So if we are to engage some resources, financial, human resources or whatever, we tend to say these are not our problems, so that should be your resources, your engagement, your involvement. Including the highest levels. So when I worked at the ministry, or now when I worked at Bratislava municipality as a physician, every topic that needed interministerial cooperation failed. There was no result. Whether they were anti-alcohol chambers as a joint initiative failed. Whenever it was in between Ministry of Health, Social Affairs or Education, no success, no achievement, just a failure. An example how to overcome this talent, I would say, perhaps it was already mentioned in previous debates, was an idea of Rudolf Zajac, our former Minister of Health, that was the author of a reform when health insurance companies would be competent in guarding the money, and then probably their involvement would change. Inside us, what we thought, we were confronted with the obstacles thrown to us by the Ministry of Social Affairs. Of course, I would say the same exists in Slovakia because I'm from the health sector. But I would say that it goes in both directions. We keep throwing obstacles over the fence that divides us. There is a mental barrier, there is a fence that's been in action since the origin of the federal state and then two separate states, and there were these fences, these walls that divide our Ministry of Health on one hand and Minister of Social Affairs on the other. And I have no recipe how to change the situation. Mr. Kamal Farhan, thank you for the invitation. Thank you for the question. Yes, I agree very much. I like what was said just now by my predecessor. I wouldn't certainly say that it's better in our country. You spoke about the interface between Ministry of Health and the one of Social Affairs. It has lasted for more than 30 years. It still exists. Such examples as, for instance, a reform of psychiatric care going across several sectors. How to solve it, how to remove the problem, I would say it necessitates a certain fusion of several entities, of several sectors. We have different policies, harm reduction policy and whatever, but there is no management effort. At the end of every 4-year mandate period, we pass it over to somebody else, and it starts from practically almost zero. If it was under the Prime Minister government at the time, the reform of psychiatric care, it would never have been implemented. It worked thanks to that. If it were left to individual ministries, it would have failed, and it wouldn't work even now. As you said, there are walls, there are barriers, there are fences in between us. This is one thing. And the second thing, I got a question just now for a television broadcasting. Harm reduction in terms of smoking and other addictions, how we will relate to previous programs, whether we will support the program, whether we will continue in it. I said there's nothing to continue in. There was an action plan by the government of Andrej Babiš. Then it was in Petr Fiala's government, but nothing big happened, and it will certainly be a part of the next government action plan again. So it always exists as a point in a government program, but it's never been implemented. It's a question of priorities. So I can speak to you about primary, secondary, tertiary prevention. I can speak to you about drug policy, whatever. But unless somebody takes it as his or her personal matter, we will just speak, and there will be no real advancement. Okay, we may speak about it as well in a while. But when you speak about management of these things, you would not fuse the two ministries. I think it's not fusible. Of course, it was mentioned, it was suggested, it was discussed, but I don't think it will ever happen. Fusion of the two ministries, I don't think it will ever happen. I could add one more name, although it's also historical name. It was started with one minister, but I will not mention the name. Okay, one more reflection. Whether the social policy of the state could contribute to a healthier population. Is there anything the state should deal with when considering, for instance, health risks prevention? Well, that's another level, but I agree that we have some 20 national plans or strategies that are being approved. We are just experts in that. Implementation is a bit worse, but approval goes very well, and drafting the strategies goes very well as well. But what must be applied is, something must be done. It's similar to a slogan, peace to the world. Unless something is done, the slogan doesn't change anything. So, again, if prevention is being considered, implementation of the prevention and the fruit will bring after our political mandate. What was the question, in fact? I forgot it. I forgot it as well. Sorry for that. But it's nice to listen to you. But the original question was forgotten by both parties. So prevention. Prevention. What we lack is motivation. Why anyone should be motivated to do it? A patient will tell you, in order to improve my health. I have my internal drive because, and this is my opinion as well, health is an individual asset. So there must be an individual interest in improving this asset, not the state's interest in it only. So whether other entities such as ministries, schools, teachers, what are their motivations? Of course, when it is evidence-based prevention, it saves lives, okay. But unless there is a somehow different motivation, it doesn't happen. So the whole task is to set up a motivation. If, for instance, for a health insurance company, there is a clear motivation why to concentrate on prevention, it will happen. If there is a financial motivation, reward for setting up motivation, of setting up a prevention, it will be a motivation. If there is no state general health insurance company, if there are just profit-based motivation, the company will take a very good care of its insured people to be in the best possible health condition. It will be in their best interest to invest in the future. But if there is a position of the director of such a state health insurance company lasting 1 year and a half, there is no true motivation behind the person. And the person will rather concentrate on topical disasters or needs than on prevention. Mr. Farhan, for now, we've been more or less in agreement. I mentioned that a mandate of 4 years is often too short, but it's the question of priorities, first of all. Politicians compete with each other, offering the public with their priorities, and unless there is somebody who stands behind the proclaimed priorities, it will probably not happen. So if we combine the three things, motivation and personal responsibility and the length of the mandate, it will bring some fruit. I can see that you have many things in common. You are both physicians, you are both members of chambers of deputies, and you are at the same time pragmaticians. If you are in the roles of your ministers now, what would you do differently in such a role? Try some practical examples, practical recommendations. I know perfectly well what I would change. Our program is based on motivation, because we believe that people do what they are paid for. This internal drive, of course, it's something that also drives you, but people rather tend to do what they are paid for. If there is zero motivation, it's a situation when you ask yourself how much money will go into the Ministry of Health, and I'm the minister. Well, this is up to the decision made by politicians. Politicians will either turn off or on the budget switch. And then there is this minister who is addressed by different entities, heads who ask for money. So investments may be done based on indicators to be fulfilled, to be reached. And these indicators are defined by the Ministry of Health. If you fulfill this or that indicator, you will be provided with this or that amount of money. And if so, the next year there will be other set of indicators to be fulfilled if the same entity is to be granted a given amount of money. So the same goes also on one floor lower, towards the patient. And how to evaluate evidence-based, for instance, the vaccination rate of children aged 12 years. In Scotland, there is 0 case of a non-vaccinated HP, the cervical cancer virus, papilloma virus. 0 rate of children not being vaccinated.
Rýchlo dosiahnuteľné ukazovateľné na rozdiel nejakej strednej dĺžky života alebo niečo, čo je omnoho ťažšie uchopiteľné a pripísateľné nejakej konkrétnej zdravotnej politike. A pokiaľ ministerstvo financií u mne dá dohromady nejakú sadu prvých indikátorov, tak si viem predstaviť, že z toho môže benefitovať celý sektor, bude motivovaný dosahovať výsledky, ktoré budú zadefinované. Ale my sme doteraz neviem ako vy v Čechách, ale na Slovensku sme nesformulovali, čo od zdravotníctva chceme. Čo sú tie ciele, ktoré má zdravotníctvo splniť. Čiže my sme do toho nalievame ročne 8 miliárd eur teraz a čudujeme sa, že ten výsledok sa nedostavil. Ja sa pýtam, aký výsledok ste čakali, keď ste nepovedali, čo za tých 8 miliárd chcete. Čiže moja predstava je sformulovať, čo za to chceme, a keď sa to nedodá, no tak tie dodatočné peniaze neprídu.
Já jenom pro vysvětlení dodám, že na Slovensku je maličko ten model jiný, že význam ministerstva financí při tom dofinancovávání je vyšší než u nás. Jo? U nás vlastně tyto otázky by si měly klást zdravotní pojišťovny a myslím, A v tom je možná taky takový malej odstín rozdílu, že si je snaží už klást, že tu určitý posun jako vidím. Možná, že o tom že se k tomu pak ještě dostaneme. Takže stejná otázka na pana poslance Farhana.
To, co tady řekl pan doktor, bylo velmi zajímavý. Ale myslím si, že to spíš vhodný pro Slovenskou republiku. A myslím to v dobrým, protože já si to jako neumím u nás dost dobře představit. Umím si představit to, že kdybychom stanovili jednotlivý KPI pro navyšování peněz do zdravotnictví, takže se vrhne, ať už na předsedu vlády, nebo na ministra, nebo na kohokoliv, desítky různých skupin, který budou chtít to kritérium prosadit, ať už to je to očkování, o kterém jste mluvil, který je třeba například u nás hrazený, jako pro chlapce, myslím, že to od 13 nebo 14 let, to možná mi tady pan doktor, magistr z pojišťovny odpoví. Já si myslím, že je to a zůstanu u těch priorit. Prostě u nás zdravotnictví v České republice, a je to i moje, je v tomhle chvíli bezplatný, nebo prostě mají nárok na něj všichni. Myslím, že to je paragraf 33 vlastně ústavy, který říká, že zdravotnictví u nás je bezplatné a i vyšetření zdraví, jako myslím tím teďka laboratorní vyšetření a další, nevím přesně, jak je tam napsané, to jsem se na to jako nekoukal, ale nějak tak to je to naformulované. Takže my musíme se na to dívat, spíš je to zase otázka priorit a priorita, pokud je zdravotnictví, tak pro tu minulou vládu byla, došlo k navýšení z 250 miliard na 500 miliard. A já si myslím, že zdravotnictví ty peníze potřebuje a samozřejmě pojišťovny by měly mít, a to nevím, jestli tady zaznělo, určitě měly mít větší vliv na rozdělování peněz vlastně a tvorbě té sítě a tvorbě těch jednotlivých věcí, ale já bych tady určitě bych nešel cestou toho, že když něco splníme, tak uděláme, dostaneme tam víc peněz. Prostě takhle to u nás nefunguje a nemyslím si, že to bude fungovat. Teď nefunguje to. Ani nefungovalo to za levicový vlád, ani za pravicový vlád, ani za současný vlády. Jenom se já tady dovedu třeba citovat nevím, jestli je to pravicová vláda, nebo byla 5koalice, 4koalice, ať jsem trochu ty politiky nesu, ale myslím, že premiér Fiala řekl, že ať už poplatky nebo další peníze, které by měli platit lidi, není pro něj téma. Kam se chceme posouvat. Prostě i tato vláda, nebo 5kolka, nebo 4kolka teďka, tak to nechává na sobě a nechce vlastně další peníze do toho zdravotnictví. Já nevím, jestli přijde potom nějaká středopravá vláda, levicová vláda, nebo já nevím, ať chcete jakákoliv, tak pokud pravicová vláda není schopná udělat jako rozhodnutí tohohle charakteru, tak co chcete potom o ostatních?
Ale dalo by se říct, že...
Mohol by som, že vbehnúť aktuálnym modelom, prepáč, že ti do toho skáčem, ale to ste mi prihrali túto tému, lebo na Slovensku máme takú skôr ľavicovú vládu. Dve sociálne demokracie a potom tí fašovni, čo tam sú, ale dve ľavicové vlády sú, dve ľavicové strany sociálne demokracie, to majú napísané. A prišli s tým, teraz premiér náš, Fico, prišiel s tým, že z nemocníc, zo štátnych nemocníc chce urobiť akciové spoločnosti a ďalší bod, ktorý bude zajtra na našej koaličnej rade, takto hrubý 40-stránkový materiál, kde budú prejednávať zavedenie poplatkov, ktoré pred 20 rokov odmietali. Robert Fico na tom si vybudoval svoju kariéru pred 20 rokmi, keď bojoval proti zajacovej reforme. A je to sociálno-demokratická vláda, ktorá tvárou v tvár ekonomické nevyhnutnosti rozmýšľa o zavedení poplatkov.
Ale na to narazí jednou jakákoliv vláda. My se blížíme nárazu do zdi, prostě ten pytel těch peněz, který se prostě nafukuje, jednou praskne. To víme všichni. To vím já, to ví tady pan magistr z VZP a další. Takže on nám to určitě řekne líp, tak to někdo řekne teda vás.
Ano, je to kouzlo toho setkání té politiky s realitou, která nastává v těch zdravotních systémech. A to napětí bude podobné, ale myslím si, že stejně tak oba ty systémy, ať už to je pro ministerstvo financí nebo pro pojišťovnu, to je jedno, ale musí se ptát, co za ty peníze dostává, musí to nějak hodnotit a podle toho ten tok peněz ovlivnit. My teďka uděláme takový skok a já se k vám vrátím a ten skok uděláme do sportu. Takže prosím opět o zobrazení spojení s paní Kateřinou Neumannovou. Tak, už se vidíme. my tu celý den hovoříme o prevenci a neustále se vracíme i k sportu a k pohybu. Ale já se nejprve vás zeptám, paní Neumannová, jak se vlastně vy udržujete v kondici po té, co už nemusíte podávat špičkové výkony v soutěžních kláních?
Tak přestože teda teď zrovna bojuju s vyrostkou, teda ta přichází v mém případě naštěstí maximálně 1-2krát za rok. Tak já se musím vrátit trošku do historie, protože to, že doteďka sportuju, troufnu si říct, že jsem fit, zdravá a v kondici, tak kdysi dávno začalo v mé rodině. To znamená, že moji rodiče ve mně přirozeně vypěstovali pozitivní vztah k pohybu a to, že se člověk hýbe, bylo u nás normální, což v současné době vůbec není standardem. Potom jsem navštěvovala různé sportovní kluby, kde prostě se mi věnovali trenéři. Nikdo z nich mi žádný sport nezošklivil, to znamená, jsem dál rozvíjela to, že sport a kolektiv okolo toho, i tu sociální vztahy jsem měla ráda. No a to, že potom se mi samozřejmě podařila kariéra vrcholové sportovkyně, která skončila jak nejlíp mohla a vlastně kariéru sportovce toho vrcholového jsem skončila a přešla jsem do té fáze, že mě jednak dál sportovat baví, ale zároveň jsem si vypěstovala to, že aby člověk se nějak cítil, aby prostě nějak vypadal, aby prostě měl kvalitní život, tak ten sport k tomu napomáhá. Takže občas se přiznám, že se mi nechce, ale vezmu občas tenisky, vezmu kolo nebo prostě jenom boty a jdu na túru do hor, když mi to čas dovoluje a pro sport samozřejmě hledám čas v návaznosti na své normální pracovní aktivity, ale mám sobě vypěstováno to, že je to prostě potřeba.
Nevím, do jaké míry máte možnost sledovat mladou generaci, ale vím, že vaše dcera dělá taková videa a přibližuje svoje sportování a myslím si, že to má vliv velký a pozitivní. Jaká je podle vás fyzická zdatnost mládeže, když to porovnáte s tím, na co jste byla zvyklá vy?
Říkat si, že je špatná, je slabé slovo, je katastrofální a zoufalá. Myslím si, že to v současné době už na datech dokazují různé průzkumy Ministerstva školství, mládeže, tělovýchovy a tak dále. A říkat si, že máme pár medailí z olympiády a říkat si, že jsme hrozně dobrý, prostě nejsme. A ten stav je opravdu problém celospolečenský, mezirezortní a pokud my všichni, kteří nějakým dílem na to můžeme mít vliv, nezačneme něco dělat, tak přesně ty dopady do státního rozpočtu v oblasti zdravotnictví a tak dále, tak tady mnoho z nich začíná. Pokud my budeme schopni děti vrátit k tomu, že je normální se hýbat a normální je vypěstovat si vztah k pohybovým aktivitám, tak je to bude provázet životem a minimálně část problémů v oblasti závislostí, sociálních problémů, zřizují se psychologické poradny, ale proč to všechno vzniká? Protože jsme se odklonili od toho přirozeného stylu života a pokud vy všichni politici, kteří na to nějakým dílem můžete mít vliv, to nezačneme brát vážně, tak se tento problém bude jenom prohlubovat a mě to samozřejmě velmi trápí. A
je tento stav, o kterém hovoříte, té zdatnosti, fyzické zdatnosti mládeže, projevuje se nějak i v tom vrcholovém sportu, že je méně talentů, nebo je to znát, nebo tam přeci jenom pořád to drží třeba rodiče, nebo prostě nějaký systém přípravy těch sportovců a není to na první pohled patrné? Tak vrcholový sport to je vlajková loď. Jednak u nás historicky prostě jsou nastavené obrovské jako takové ty motivace i v rámci rodin a říkat si, že za všemi olympijskými medailemi nebo velkými sportovci je systém, není to pravda. Jsou to mnohdy opravdu rodinné týmy, teď ale neříkám, že ve všech případech to tak je, ale mnohdy jsou to opravdu nadšené rodinné týmy, jednotliví trenéři a tak trošku jako pozitivním slova smyslu blázni, kteří opravdu věnují svůj volný čas a život sportu, tak to asi, o tom to úplně není. V tom vrcholovém sportu já věřím, že vždycky nějakou hvězdu mít budeme a když do vrcholového sportu půjdou nějaké rozumné prostředky, tak ten efekt tam je relativně, nechci jít snadno dosažitelný, ale je tam. Ale další obrovský problém je právě podpora sportování mládeže, která nemusí mít za cíl vychovávat olympijské medailisty. Děkuji pěkně pro tuto chvíli. Pánové poslanci, na vás se znovu obracím. Jinak by mě zajímalo, jakým se věnujete vy aktivitám, abyste předcházeli rizikům jako sportovním. A jednak, jak vy vnímáte problematiku mládeže, jeho pohybu? Je to něco, co by se mělo politicky řešit, nebo finančně nějakou dotací, anebo je to úplně někde z jiného konce byste to rozmotali? Tome. když se schopil mikrofonu?
No, chodím do záhrady, rilovať, pilovať a tak ďalej. Toto je obrovský relax, pretože vidím výsledok svojej práce hneď a nikto iný mi ho nepokazí. Jedne si ho sám pokazím a to mi dáva, to je tá energia a všetko ostatné, nešportujem veľmi. A teda, aká je tá situácia, čo sa týka mládeže? My sme špeciálne v našom Bratislavskom kraji sme robili v spolupráci s regionálnym úradom verejného zdravotníctva, teda s hygienou, pred pár rokmi veľký prieskum na školách. Sme zriaďovateľ stredných škôl, takže sme vedeli na tých stredných školách pozerať, aký je ten stav, obezita, cholesterol, jedno s druhým, tretím, štvrtým. No, je to zlé. Je to zlé a problém je, že sa nerobí sa s tým a myslím si, že je to o tých motiváciách opäť. Ja som presvedčený, že je to o tých motiváciách, lebo keď bude niečo priorita, tak potom tam musím dať aj motivácie, aby s tým niekto niečo robil. Aby napríklad pediatri boli motivovaní toho pacienta alebo také dieťa podchytiť, aby sme mali kam ho poslať tou cestou pacienta, ak potrebuje nejaký konzulting, nejaké poradenstvo, čo má robiť. Absolútne nám chýbajú súťaže, kde by sa mohli zúčastňovať všetci, nie len tí najtalentovanejší, lebo zvyčajne akože ten, kto uteká pre tú loptu na tej telesnej výchove, je ten, kto s tou loptou chce hrať, nie ten, kto sa s ňou hrať nechce. Ale treba vtiahnuť všetkých do nejakej spoločnej aktivity a to nám chýbajú takéto typy súťaží. Nechcel by som ako stínový minister zdravotníctva zasávať do toho školstva natoľko, ale myslím si, že vo veľkej miere tu má aj školstvo svoju rolu. Veľa sa u nás rozpráva o tom, dokonca teraz pripustil náš minister školstva, že by to teda tam aj možno niekde osadil, pretože predtým bol ministrom zdravotníctva, pán Drucker. A to je, že zdravoveda, ako výučbový predmet pre školákov, a to by zrejme teda malo byť aj, keď už nie predškolskom, tak minimálne v tom školskom veku ako predmet, len vždy potom tie ostatné predmety povedia na úkor koho to bude, lebo my vám nepustíme dejepis a my vám nepustíme hodinu z biológie a potom tie sílaby vyzerajú tak, ako vyzerajú. Ale toto je tá cesta, ktorá tu momentálne nie je. Ako ja si pamätám zo svojich, pred 89. roku, zo svojich detských liet na škole, že takéto typy osvety a pôsobenia a školská sestra, ktorá bola na škole, s ktorou sa dali riešiť nejaké jednoduché zdravotné problémy, to tu bolo a dnes už nie. Sestry nemáme, ani vy, ani my a zdravoveda sa niekde vytratila.
Takže jsou to spojené nádoby, zdravověda, možná i ty hodiny tělesné výchovy, které jsou třeba u nás taky malém penzu. Pane poslanče.
Tak já...
Well, I think I'm an athlete. I go skiing in winter, I play soccer, in the summer go cycling. So I think that adequately to my age, I try to do some sports. In terms of school kids, I think that we'll all agree. When I was young, when I was a kid, I went to school, I came to school, I put my bag in the classroom and I went outside. And then after classes, I went outside again and just ran around. And this is something our kids today miss. I have 2 kids, so I see the kind of things they do, the work on computer. My son studies mathematics and physics at university, so I can see the amount of work on the computer.
To znamená na to školství, protože ať už to jsou, jste mluvil, edukační programy, školení, vlastně, ať už je to dané do výuky, podpora tělesné výchovy, ale chybí tady prostě takový ten mezistupeň. Za nás přece byli, teď nechci říct Sokol, nebo jako, ale chybí tady prostě, aby ty děti jako byly vedený k tomu sportu. A pokud to nebude dělat škola, nebude to škola motivovat, tak si myslím, že v dnešní době ty rodiče to neutáhnou. A musí to být, teď použiju to slovo, kdy mluvím o motivaci, já jsem mluvil o prioritách a já to teďka spojím v tom smyslu, že pokud se to stane prioritou pro toho ministra školství nebo ministra zdravotnictví, tak pak musí samozřejmě motivovat ten svůj rezort, nebo musí motivovat ty školy nebo ty zařízení, aby k tomu vedli. Takže to je asi za mě. Děkuji.
Děkuji, Tomáš se doplní.
Ak som si spomenul, že ešte čo som nepovedal slovné spojenie, neviem, či už ma pustíš slovo, keď toľko si beriem ten mikrofón, to sú, že determinanty zdravia. Keďže prednášam zdravotnú politiku, tak akože toto je môj obľúbený graf, ktorým trolujem zdravotníkov, že ukážem, čo sú determinanty zdravia, akým podielom sa ktoré faktory podielajú na našom zdravotnom stave a na tom, že či predčasne zomrieme alebo nie. A zdravotníctvo, zdravotné služby, kvalita zdravotníctva, dostupnosť zdravotných služieb v tom najlepšom prípade možno 15% prispieva k tomu koláčovému grafu. Všetko ostatné je mimo zdravotníctva. Sú to tie socioekonomické, lifestyleové, genetické, životné prostredie a tak ďalej, iné faktory. A tam nemáme akože zabodnutú tú vlajočku. Čiže ja niekedy tak akože polovážne, ale aj s polotrollingom hovorím, že možno namiesto toho, že dáme ďalších x desiatok miliónov do 25. statínu zaradeného do kategorizácie, keby za tie isté peniaze kúpime deťom na 10. na svačinu akože jablko, tak dosiahneme možno lepší efekt at the end of the day, ako tým 25. statínom v tej kategorizácii, ktorý akože nedelia, nenásobí zdravotný stav populácie.
Děkuji. Často bývá ministr zdravotnictví terčem takovým jako opravdu vděčným terčem, co všechno není v pořádku a co má udělat. A to mě napadá, že to je vlastně příležitost, aby ministr zdravotnictví se změnil svoji roli a v příští vládě bouchal na ostatní ministerstva, úkoloval je a říkal jim, co mají dělat. Obrazně samozřejmě vím, že kompetenčně to možné není. Obracím se teďka, předpokládám, do Bruselu, že pan poslanec Tomáš Zdechovský se nachází tam. Můžeme se spojit? Vidíme se? Slyšíme se?
Slyšíme se i vidíme se.
Tak, pane poslanče, nejprve ještě, aby jsme nezůstali nic dlužní tomu sportu. Vy jste patrně sportovec, protože vás vidím často na sociálních sítích v nějakých sportovních pozicích, takže jste aktivně, bych řekl, myslím, že to je fakt výborná věc, protože máte nějaké sledovatele, takže jenom nám přibližte, co vy považujete z těch aktivit jako pro sebe jako nejlepší, z těch pohybových, řekněme, a pak, jak vy si představujete, nebo co byste viděl jako nějaký faktor, který by mohl změnit to, co jsme tu říkali o naší mládeži, o tom, že jejich pohybové prostě zdatnost, fyzická zdatnost je nízká.
Tak dobré odpoledne, dámy a pánové. Já chci říct, že každý den chodím, pokud to čas dovolí, běhat a každý den cvičím. Vlastně máme i takovou aplikaci v mobilu, která mě nutí, vždycky mi píše, když necvičím, aby šel cvičit, a myslím si, že ta sebemotivace vlastně i pracovat na sobě, to je, jako bych řekl, nejlepší faktor na to se sebou něco dělat. A tím, že stále jsem voják aktivní zálohy, tak my máme každý rok přezkoušení a při tom přezkoušení musíte splnit určité limity. A samozřejmě, že když jste ještě k tomu europoslanec, tak se na vás daleko víc ty lidi dívají a daleko víc se ptají, jestli to zvládnete, takže se snažíte vždycky podat maximální výkon. A já už mám takové zjištění, že to prostě za měsíc před tím přezkoušením nedoženete, takže je lepší sportovat průběžně. A samozřejmě, když mám možnost plavat jakýchkoliv kolektivní sport, fotbal, basketbal, volejbal, tak jdu si zasportovat. Já třeba bych nebyl vůbec tak skeptický. Tady jsem slyšel ohledně prevence, jak ty děti na tom jsou a jak je to špatný. Já mám tady nějaký přehledy.
Read some survey from the 27th EU member states. For sure, obesity is not yet tragical. We have excessive cases. We know about of population, there are people who do not want to move. But when we look across the member states, we can see that the problems are practically similar or even worse in some other countries. So we should speak about it more. We should collect more positive examples. We should involve probably more celebrities, people who can show that sports is something helpful for every human being as a certain prevention not only deterioration of physical health, but also mental health. We saw it on the COVID period. People got closed, not being able to socialize, and many of them began to develop mental problems. So I would see a motivational system as the best one. You exercise, you do something good to your body condition, you have a healthy lifestyle, you do not smoke, you do not consume alcohol systematically, you just take a drink from time to time, and if so, you may get some benefits in your health insurance contribution. This is something all governments in this country fear extremely, whether they are rightists or leftists. And still, I think, since it works already in other countries, it can be well deployed. If you do something for your health, you can be benefited. I don't know, you have a discount in your health insurance contribution, or you get something else. You may be given a term for your surgery sooner than somebody else. So these are sorts of motivation that could be used now. If people do not feel motivated enough already when they exercise and think they feel subjectively better. So putting more money on the prevention, I would say we spent enough of that. For instance, last year it was several billion euros into prevention programs. So I think that's enough. It's rather the way that people should get aware that this is their thing. And unless they understand this, nothing will change in the Czech Republic, Slovak Republic, anywhere. Yes, indeed, these motivational schemes could be part of political programs of different parties. Why not? However, the European perspective, if I ask you what's the role of European Parliament in the prevention of health risks, I would return the question, what should be tackled on the national level and what should be tackled on the EU level? I would say health is not to be tackled on the EU level, which in my view is a pity, because as I can see, we struggle with similar problems when we look at different MS. So it would be good if we could, for instance, share medical data across the EU or good practice examples, or if we could motivate each other or even compete with each other in terms of who, for instance, in 2024 or 2025, advance their prevention in terms of some specific illness. So this could change the perspective of health prevention. This could be something that the EU could coordinate and highlight the good practice and invite the experts and try to bring solutions to national tables where national politicians would choose following their political programs. Thank you very much. Please, Mr. Zachovsky and Mrs. Neumannová, stay still online. There will be the second round of my questions. Now there will be Ondřej Knotek's message. He's a member of this health subcommittee of the European Parliament. So let's watch the video. Good day, ladies and gentlemen. Thank you very much for this opportunity to be part of this debate that is dedicated on the health prevention and sustainability of healthcare ecosystems. I'm speaking to you as the European Parliament member. You may ask why, if national health is within competence of the member states. That's true. However, Brussels, I mean the EU, tries to do at least something across the entity. We still the European Parliament, the health is a part of environment, a foil or folder, and there has been recently established health subcommittee. And on the level of this subcommittee, there will be soon a decision taken whether it will become a full competent committee or whether it will remain on the level of subcommittee. I'm the only Czech who is a member of this health subcommittee. When speaking about prevention, I would say clearly that the European Parliament speaks about it a lot. When we look, for instance, at the European Programme Against Cancer, participated to very much last year by the EP. As a matter of fact, the set of measures envisaged were passed from prevention to diagnostics as well. And if there is a political consent on, for instance, diabetes or chronic failure, renal failure, insufficiency of renal organs, there will be, if we agree on it, there will be more money invested on prevention and diagnostics and treatment under the chapters of our national health systems. And if so, there will be money available for very expensive but very rare and important devices, such as the one that was used for little Martinek for his renal insufficiency. And to be able to base those strategies on evidence and to orient them properly, it will be further effort of European bodies. And if I speak about it more generally, European funds should be used to increase attractivity of various regions, leveling up regions in terms of medical facilities, sports possibilities, culture possibilities, and so on and so forth. My video message is rather short, but I appreciate very much the possibility to speak to you at least this way, and I'm looking forward to our mutual cooperation in the future. Thank you very much. We can see that some of the plans, some of the programs can be related to European funds, such as different sports activities. And I will now address Chief Hygienist and Director of the State Health Institute, Mrs. Barbara Macková, asking her where does she see the role of her institute in the prevention of health risks. Thank you very much for the floor and for the invitation. I cannot start but saying that the State Health Institute was established 100 years ago in order to survey and prevent health risks for the then Czechoslovakia. And throughout those 100 years, it's been an institution dedicated fully to evaluating health risks and implement activities that are meant to prevent health risks, so primarily to prevention. And as already said several times, evidence-based evaluation of health risks.
Když se podíváte po světě a vidíte různé modely toho, jak zorganizovat.
When you look at different healthcare models throughout the world, what's our position? What are the pluses of the Czech model? What are the minuses? What do you lack in it? The Czech model, thanks to its history, was at a certain time an inspiration for many other European models, how public health system should be organized in a given country. And when we spoke about environment and monitoring environmental risks, 25 years ago, we used to be leaders in this domain. Many projects were carried out, and we had a very good position, not only in Europe, but worldwide. Today, I can say that we are rather in reverse we are getting back to this right position, to the nice position, to equal the countries that have developing this sphere without interruption. And we used to invest money, especially into treatments, into clinical therapies, while prevention of health risks was something that was rather neglected over the last 25 years. And therefore, still today, investments into health risk prevention are rather little today. And this is the answer to your question. This is where I see our reserves. When we were sitting here at the previous conference, I said I would love to have National Council for Public Health in the Czech Republic, and I'm very happy that we do have such a body today. This is my reaction to my predecessor says this gives us a chance to discuss intersectorially about health risks. There are things we have to change, and motivation that should lead us forward is that once we have this public health accessible to everyone, motivation to take care of one's own health is paradoxically very low. Also due to the fact that I know that if I have any health problem, there is a physician and she is bound to help me. Unfortunately, some problems cannot be solved anymore, and I continue living with the disease. And so we have to get back to what is needed. I mean, motivate ourselves and also the society to be interested in good health of people so that people take care of their prevention. And I can only confirm that up to 80% of all illnesses, whether they are infectious or not, they are preventable by a good lifestyle, by a sound environment, and by all those non-health aspects we live in. One more question from me, resulting from today's conference. We had a panel of medical experts, and there was a strong criticism against vaccination situation. I know that you are troubled with that, concerned that this is not something you neglect. But do you think there can be a stronger voice of personalities that relate somehow to vaccination, as you, main chief hygienist? Seems that the discussion is rather feeble, modest. There are different opinions on vaccination in social media, and seems that we are still rather in defensive while supporting vaccination. Vaccination is for sure a major topic. It is one of the most excellent instruments of prevention. Thanks to all what you have just described, we rather make vaccination complicated. We should reverse the discussion so that it's more understood that vaccination is a positive tool that improves the health. And since we do not solve only vaccination problem, but also antibiotics resistance, this is another front line we have to concentrate on. Overuse or excessive use or improper use of antibiotics is something that is a major problem of health professionals throughout the world. If you get back to vaccination, if you have a person that is convinced of something very strongly, well, I found out that I can explain the person that she is wrong. I can provide evidence-based arguments, but, and we meet with this every day, we are rather in a retreat. Variable, checkable, valid information people could consult is still rather scarce. It's getting more and more numerous, but still it doesn't win over, I would say, conspiracy theories. You know the story. You hear, you come to a physician and there is a little text on his or her doorway. I do not give second consultation after Dr. Google consultation being the first one. So we have to work with those, and we do our best. But what was said several times already, motivation and primary input should be on the person herself.
Prostorem, v kterém je obrovská anonymita. A já vlastně leckdy jsem se potkala s tím, že člověk nebo někdo, kdo na těch sociálních sítích i má tyhle ty agresivní názory, tak pak, když si s ním člověk povídá osobně, tak to vlastně tak vůbec jako není. A on tím hledá ty lidi, kteří ho budou vlastně obdivovat a hledá si vlastně ty zájemce, takže je to velmi komplikované. Určitě to není jednoduché, ale to, co je potřeba vlastně pořád opakovat a bohužel nejenom veřejnosti, ale i mnohým odborníkům, je to, že vlastně třeba očkování je právě jedním ze zázraků medicíny, by se dalo říct, protože předejít nějaké nemoci je opravdu, se málo komu podařilo a myslím, že nám se to daří tímhletím způsobem.
Děkuji velice pěkně. Vlastně ta úvaha směřuje tam, jestli by nemělo být vlastně ty věci kolem očkování přece jenom více autoritativní, semknutější, jako by ta odborná společnost s hygienou a jako víc být tak jako takhle to je, protože asi nemá smysl diskutovat s těmi, kteří jsou úplní odpírači. Já nevím, jestli, pánové poslanci, máte na to nějaký pohled, jak prostě zlepšit pověst očkování a zvýšit tu proočkovanost. My jsme řešili třeba katastrofální situaci u chřipky v České republice. Myslím, že na Slovensku to bude možná podobné, nevím, jo. Horší to snad ani nemůže být, protože je asi 8% a 20% u seniorů a no.
Celkovo to máme menej ako 5%, 4, niečo.
Takže môže byť i už ešte, áno.
A takto, a začal to doktor. Jak dneska si to pamätám, 22 rokov, bol to v 2002 roku, primár neurológie v univerzitnej nemocnici v Bratislave v hlavných televíznych správach povedal, že mal pacientku, ktorá mala nejaký Guillain-Barrého syndrom alebo Kerry fraz, nejakú neurologickú poruchu, potom ako bola zaočkovaná proti chrípke. V tej sezóne padla očkovanosť na 2% a nikdy sme sa z toho nezotavili. Hej, to akože začali doktori šíriť tieto hoaxy. Nemal na to evidence, ale dal svoj pocit, dojmológiu, anekdotu a už sa to zvier, však aj doktori to povedali v televízii, tak prečo by sme sa dali očkovať. Ja to hovorím cez KPI, dajme úlohu, bude KPI, má byť taká zaočkovanosť pre poisťovňu, poisťovňa musí hľadať moment motivácie pre lekára, zaplatíme ti väčšiu kapitáciu, dostaneš bonus ku kapitácii, keď podchytíš tých svojich blablabla. Det to pre pacienta, keď prídeš tak. To sme tu ešte možno nezdôraznili, ale v predchádzajúcom bloku sme to počuli, že benefity zdravotných poisťovní, teda niečo nad rámec, že tým akože ťahajú a motivujú tých poistencov nie preto, aby sa prepoistili, aby preto, aby niečo urobili so svojím zdravím. Na Slovensku to fungovalo ako víno. Povedali všetky tri zdravotné, začala to jedna, potom druhá to odkopírovala, Všeobecká sa musela pripojiť, že všetky tri to ponúkali. Budete chodiť na preventívnu prehliadku u gynekológa, u všeobecného lekára, u zubára a zaplatíme vám dentálnu hygienu. A ľudia išli po teplých rožkoch. To bolo obrovský úspech, teraz sa to zrušilo, čo je to malo zase obrovskú kritiku. A tak ľudia fungujú na incentívy, ľudia sú motivovateľní a takýmto spôsobom sa s tým hrať. A ešte jednu vec mám, neexistuje riešenie v zdravotníctve takého typu, akože one size fits all, že jedno riešenie pre celú krajinu. A ja som sa teraz pozeral na dáta o očkovaní proti HPV, lebo teraz akože posledných pár rokov sa veľmi intenzívne robím očkovacie dni proti HPV v Bratislave a teraz sme pozerali dáta, analýzu som dal robiť a tak ďalej po celom Slovensku. Ako sú zaočkované deti proti HPV u jednotlivých pediatrov? A je to veľmi nerovnomerné a rôznorodé a nie je to ľahko vysvetliteľné, že toto je kozmopolitná Bratislava a toto je zaostalý ďaleký východ a tuto akože nevedia a tu vedia. Nie, nájdeme aj na zaostalom východe okresy, kde akože že naozaj solidná zaočkovanosť na západe Slovenska menšia. A ja hovorím, že správne riešenie je ísť sa pozrieť do toho okresu v tej Banskej Štiavnici u nás alebo v Humennom, kde majú tú vysokú zaočkovanosť a pýtať sa ich, a čo robíte vy preto, aby ste tu boli úspešní? Lebo to, čo funguje u nich v Humennom, nefunguje v Bratislave a pokiaľ niekto v Bratislave na ministerstve povie, že teraz stratégia je takáto a všetci píšte modrým perom, no tak to jednoducho sa vypomstí. Ako tie riešenia musia byť lokálne, lebo tie lokálne
the local hoaxes, that's something you cannot order. I remember Slovakia in my youth. Slovakia is really a very differentiated region. Now, let us move on to health insurance companies. And I'd like to ask about the increase in the volume of money dedicated to prevention. Have you seen any effects within the general health insurance company? Well, the legislative barriers for the creation of the prevention fund have been lifted. Well, yeah, but that's a different thing. I can get back to that. But focusing on the measures of the current government, we've managed through the board of directors. We have a board of directors which approves a plan which includes the prevention plan. So for this year, we've managed to reach an increase. Now we are at a double of the amount against last year. In the past, you'd have to go with the contributions to the specific clinical workplaces. Now you can apply online.
Příspěvky, to znamená, vy jste eligible, nebo jste oprávněn čerpat ten příspěvek pouze, když uděláte něco. A vlastně to je ten samý případ, co tady říkal pan stínový ministr ze Slovenska s tou dentální hygienou, protože ta dentální hygiena je poměrně nákladná záležitost, stojí od 500 do 1500 korun zhruba v České republice, my dáváme 1000 korun, ale podmiňujeme její čerpání takovou tou bazální prevencí u praktického lékaře. A skutečně ta data z letošního roku ukazují, že jsme na číslech, která předcházela více zkrátka lidí chodí na prevenci ještě před tou covidovou jako pauzou, kdy vlastně ta adherence byla výrazně pak nižší. To znamená, samozřejmě to není jediná příčina asi toho nárůstu, těch příčin je celá řada. Pan doktor Šonka, který doufám už odešel, by vám řekl, že za to můžou samozřejmě jenom praktičtí lékaři a jejich větší aktivita. A samozřejmě asi korektní odpověď je, že to je mix všech vlivů dohromady a my se můžeme dohadovat a měřit to, kdo má v tom větší úlohu. Ale to je furt podle mě jako málo. Jo? Tohle jsou takový spíš jako jemnosti, co se týká toho fondu prevence. To je nějaký doplněk, který ty zdravotní pojišťovny používají vlastně k akvírování nových klientů, respektive k retenci těch stávajících. A některé příspěvky, řekněme si to otevřeně, plní takovou funkci spíše sociálního příspěvku, jako příspěvek na pohybové aktivity. Já dost dobře nezměřím že vedl k, já nevím, záchytu nebo k rozvoji diabetu o nějaké procento, to prostě nedokážu spočítat. Takže já si spíš myslím, že ta diskuze by se měla odehrávat jinde a tady vlastně některé ty nápady podle mě jsou jako žádoucí je prosazovat do praxe, to znamená bonifikovat, respektive sankcionovat některé typy segmentů za to, jaký mají stav v kmeni, si myslím, že jako vůbec není od věci. A mnohdy stačí třeba, vím, že v Belgii existuje ten institut, který pracuje pro ministerstvo zdravotnictví, to je něco jako náš ÚZIS, když bych to měl připodobnit, tak ten jenom sdílí třeba data mezi praktickými lékaři o proočkovanosti populace v určitých typech teda preventabilních onemocnění a už jenom to sdílení těch dat, že prostě tady ten v tomto regionu má proočkovanost 80% a já mám 60%, tak vede, že já se o ten kmen jako líp stačím. Takže to nemusí být intervence tvrdá typu šáhnutí na peníze nebo tak, byť by byla asi nejefektivnější.
Já o vás vím, že jste nedávno dokončil studium na Oxfordské univerzitě a máte diplomovou práci, kde se také věnujete prevenci. K jakým závěrům jste v té diplomce došel?
Děkuju. No, já jsem se věnoval prevenci v oblasti toho přístupu harm reduction, protože Česká republika jako furt vyniká v negativním slova smyslu v míře denních kuřáků v populaci. My máme asi 25% denně kouřících lidí a třeba ta Velká Británie, kde mně přišlo teda, když jsem šel po ulici, že každý kouřil, ale tady mi to tak nepřijde, ale prostě Velká Británie vykazuje oficiální data, že má třeba 15%, což je rapidní jako úbytek za poslední. Oni měli taky 25%, ale ten trend jde výrazně níž v tom odvykání než u nás. A mně přišlo žádoucí, abych to nenapsal jenom tu diplomku jen tak a pak ji hodil někam do koše, tak mně přišlo žádoucí se zaměřit to, protože máme na starosti ve VZP fond prevence, tak jako vytvořit nějaké podhoubí pro to, sebrat intervence zkrátka proto, abychom mohli vytvořit v budoucnu program, který bude zaměřený na odvykání kouření. A udělal jsem systematic review všech různých intervencí, které se jeví jako žádoucí a vyšlo mi takových 5 základních kategorií, které jsou
of what should be demanded from public policies and pushing through less harmful alternatives is probably one of the basic interventions we should do. And actually, Great Britain has based its approach on this. They want to get the number of smokers down to 5% from 15%. And the way to that is through e-cigarettes. Of course, it needs to be combined with various behavioral interventions, tapes, patches, education. That's primordial too. But I think it's definitely worth looking in this direction. And in the beginning, we heard Deputy Farhan was a bit skeptical, and I mean, he was right, but I can't say that aloud. He said that the harm reduction approach has existed in the governmental agenda for many years, but to make it really practical, it'll be hard to find an institution that would be responsible for that. I know there's been a huge debate. Professor Moravchik will probably confirm what I'm saying. The National Anti-Drug Coordination was trying to push through the less harmful alternatives, and one of the proposals was putting a bigger tax on these less harmful drugs. So I mean, when you put it in the governmental agenda, it's far from being implemented in practice, and I think it's a pity because the approach is evidence-based. I'm sorry to hear that. And Associate Professor Moravčík, talking about addictions, to what extent are they preventable, and what kind of secondary and tertiary prevention tools which are effective do we have available? Well, we've already heard that today. I mean, I don't like this terminology, primary, secondary, tertiary, because there are different schools, different public health schools that use different terminology. So I like talking about prevention, early intervention, treatment, and so prevention of recurrence. And I think that the area of addictions is an example. So it's a thing that needs to be dealt with by several ministries. Public health needs to be considered a public problem, and health is definitely an individual value, but it is also a public asset, because healthcare is a public service. Health means lower or higher GDP. And lifestyle and health determinants need to be perceived from this public perspective, and we need to influence the state. And when you talk about prevention in medicine, we frequently talk about screening programs, early intervention, and so on. And then, all of a sudden, if we want to change people's behavior, we start talking about awareness raising. So we tend to reduce prevention down to awareness raising and changing their attitudes, as if the physician should educate people. They don't have time for that. Talking to people in a way, changing their attitudes and behavior, that would be ideal. And I mean, it's true. But the whole society, all politicians need to act in a certain way. Set the way the tax system is set up has an impact. People are consumers of products, so we need to influence people's conduct the right way, so that they wouldn't buy alcohol. They would buy alcohol which is less concentrated. We need to make them buy less risky products, not cigarettes. So it's part of our strategy, part of the governmental declaration. We want to reduce the dependence and addiction to harmful products. We've heard about tobacco and substitutes for tobacco. We know about the benefits, but we are unable to actually implement it. And it's not just about price availability, it's also about physical and time availability of the products, where and how you can get to these products. And it's not just about addictions, it's also about all the other determinants of the health condition which stem from the socioeconomic situation and health condition of the patient. And one last thing I want to say. People who can't control their conduct well enough are frequently in a complicated socioeconomic situation. They have usually mental problems, and their morbidity lasts for some time. There's a syndrome of various factors, and they are vulnerable. So I totally agree that we should push people in the direction of healthier conduct. Dental hygiene, that's a perfect example. And but if it leads to conditioning the availability of healthcare, meaning you don't do enough physical activity, so you'll go later for the surgery, or you smoke, so you are not entitled to this or that intervention. I would consider this really harmful, because the result would be that those who are more privileged, who for various reasons act in a less risky way, I mean, responsible or irresponsible conduct as a term doesn't fit in the healthcare system. We should think about the risky behaviors that we can affect. So I would definitely not go for changing the conditions for the approach to healthcare based on their risk profile, because we would put disadvantaged people at an even greater disadvantage. Okay, thank you for these closing words. Let us wrap up with a series of recommendations. Each one of you, what would be your recommendation in the area of prevention? You can pick any area that you like. What should the state do? Now we've heard that the Czech Republic has a declaration of the government, which is still on paper. What should the state do? Okay, currently I deal with the drug policy and the availability or the change of the availability of psychoactive substances. And before we change the gap between legal drugs, so to say, which is tobacco and alcohol, and the illegal drugs, our policy won't make any sense. We won't be able to benefit from all the different possibilities that are available in the area of prevention. It's stupid and foolish to punish people with jail sentence for holding 10 grams of cannabis. We need to put this area under control, make a single framework for all these addictive substances, and we should control all the different risks related to lifestyle. So it should be part of health prevention as such. Thank you. Director, what should the state do or enforce, and what still doesn't exist? I know that you're the state representative, in fact, but just imagine you are not one of these and you're just here as an individual. Thank you. We're talking not only about prevention, but also about economics. So I'd really appreciate if, we were talking about the funding of healthcare, and I'd really appreciate if we talked about the possibility and the amount of money that we'll put in prevention and health risk assessment, and in the fulfillment of indicators, so that we can improve the health determinants. Because if we only talk about it, there won't be any outcome. Tom, well, I'll just repeat what I said. First and foremost, the state needs to define the indicators that we should fulfill. If they don't define them, we will work without any results. So the state needs to say what the parameters of prevention are and how we should do that. Okay, I'll be brief. From what I've said, I think it must have already been clear. There is a number of action plans, many good ideas and suggestions, and the only possibility is just starting with what we have and implementing it. And then I am convinced that that's enough. If we do this, we'll move forward. But the plans need to define exact responsibility. Yes, There's a lot of things like that, but most of them are not implemented. Deputy, yes, we've heard a lot of things already, most of them I'd say too, but I'd like to change the paradigmatic approach to money spending in healthcare, because the majority is dedicated to therapy and zero to prevention. The system is set for treatment, not for prevention. So maybe we need to change the way the society thinks. Okay, thank you very much. And I'm sorry, I need to apologize to our online guests. I'm not sure whether the deputy and Kateřina Neumannová are still with us. No, they didn't make it. I was going to ask them for their recommendation, but unfortunately they are not here anymore. So thank you. And maybe we'll ask them separately. Our editors will approach them. Thank you very much for staying with us until the end. I wish Tom a good trip back to Slovakia. I thank you all for staying with us the whole time. Thank you for spending, I believe, an interesting day together, and I look forward to seeing you again at the 5th conference entitled The Economy of Prevention. Thank you very much and have a good afternoon.